In this video, we will explain some important terms related to brain health and memory. These terms will help you understand more during our webinar. Let's get started. Brain health means keeping your brain strong and working well, just like exercising keeps your body strong. Reading, exercising, eating healthy, and staying social keeps your brain healthy. Cognitive impairment means that your brain isn't working as well as it could. It can make it harder to think, remember, or solve problems. Dementia is when someone has problems with memory and thinking that get worse over time. It affects how they remember, talk, and understand things, and the care they need. Alzheimer's disease is one cause of dementia. It is a condition that makes it harder to remember things, think clearly, and changes behaviors over time. Risk factors are things that make it more likely for someone to get dementia, like high blood pressure, diabetes, hearing problems, or smoking. Comorbid conditions means having more than one illness at a time, like dementia and diabetes. Dementia can make these other illnesses harder to manage. Digital cognitive assessments are quick tests on a phone or computer that check how sharp your brain is and how well it's working. Sometimes thinking problems are caused by things we can fix, like low vitamins or certain medicines. Doctors run tests to see if these problems can be reversed. Now that we've explained these terms, you'll be ready to understand more about brain health. Remember, taking care of your brain is just as important as taking care of your body.
The Davos Alzheimer's Collaborative is leading the largest global initiative of its kind for Alzheimer's disease. We drive scientific discovery, aligning innovation within health systems to help people worldwide, including those in low and middle income countries left out of previous efforts to fight Alzheimer's.
The Davos Alzheimer's Collaborative System Preparedness Program started a number of years ago. System preparedness really looks at how do we take novel things like blood-based biomarkers and put them into routine clinical practice and really track in a systematic way what would need to change in policy and practice and system operations for that novel technology like blood to become widespread and accessible globally.
The Davos Alzheimer's Collaborative for Healthcare System Preparedness, also known as DAC-SP, was launched in 2021 with the purpose of catalyzing healthcare system transformation, improving patient care, and providing inclusive access to treatment. Late diagnosis, treatment uncertainties, and operational inefficiencies to implement changes are challenges in health system preparedness we are facing worldwide. DAC-SP works to address these challenges through efforts to increase early detection of cognitive impairment, projects rooted in global and local collaboration, and leveraging shared insights to create a blueprint for health systems everywhere. Our organization intends to achieve its mission using two interrelated approaches. First, develop a funding mechanism to encourage and support multiple diverse projects aimed at common operational challenges. Second, bring together representatives of health systems from multiple countries across the high, medium, and low resource spectrum to engage with, inform, and learn how to best introduce new methods that can be replicated into their own operational systems.
We're using this DAC opportunity to collect data we need to advocate for the long-term changes we're envisioning.
DAC-SP strongly believes in the importance of early detection as it relates to achieving better patient outcomes and the ability for health systems to rapidly benefit from research and innovation. Early detection flagship programs were implemented in 7 sites across 6 countries: Brazil, Jamaica, Japan, Mexico, Scotland, and the United States. Grant programs have been implemented in Armenia, Brunei, Canada, Cuba, Germany, Japan, Kenya, and the United States. Early detection flagship sites in primary care implemented a future state model, including digital assessments to detect cognitive impairment and a blood-based biomarker to measure potential AD pathology.
Our mission? Let's take these innovations that are coming out of research and make sure that they get to the bedside. So, we are right on the cusp of some of the greatest research successes in Alzheimer's disease therapies, and we've already got amazing diagnostics available.
Ultimately, our vision is a world where older people can live longer, healthier, and happier lives, in a manner that is culturally relevant and ensures their dignity and equality. To learn more, please visit the DAC website or follow us on social media.
Welcome to Amaji Health Limited's webinar to share the findings from the Davos Alzheimer's Collaborative, or DAC, Healthcare System Preparedness Flagship Project in Jamaica on detection of Alzheimer's disease and related dementias. My name is Ishta Govaya, and I was the Jamaica site lead for the DAC Flagship Project in Jamaica. I'm a researcher, psychologist, and founder and CEO of Amaji Health Limited, a company offering training, care, and consultancy for healthy aging and brain health. I'm also a senior consultant with the World Health Organization, a nominated member of the World Dementia Council, director on the board of the Caribbean Policy Research Institute, and a member of the Clinical Management Committee at Bellevue Hospital in Jamaica. Some key findings from the 2024 World Alzheimer's Report, published by Alzheimer's Disease International, provide important groundings for our conversations today. Globally, 80% of the general public think dementia is a normal part of aging, rather than a medical condition. 65% of health and care professionals incorrectly believe that dementia is a normal part of aging. The DAC Healthcare System Preparedness Program focuses on preparing healthcare systems for the integration of innovations. In the flagship program on early detection, the specific innovations were in the diagnostics category, meaning that they are tests or procedures that help identify a disease or condition in a person. And in the flagship project, these diagnostics were in the categories of digital cognitive assessments and blood-based biomarkers for Alzheimer's disease. In the DAC and similar programs, these diagnostic innovations are meant to facilitate identification of persons eligible for disease-modifying therapies, or DMTs, which are pharmacological or medicines interventions that change clinical progression by interfering in the underlying mechanism of the disease process. Such programs raise important questions about healthcare system preparedness in contexts where the burden of disease is high and where healthcare systems are fragile and disconnected from long-term care. This is one of the reasons why it was crucial to have a country like Jamaica participate in the flagship projects. Today, we will learn more about the DAC Healthcare System Preparedness Program of Work and the Jamaica site's adaptation and key experiences. We will hear 3 key stories: a story about the patients, a story about the medical doctors, and a story about the research team. As you listen into these stories, please keep in mind to use the question and answer feature to share any questions and the chat feature to share general comments. After the first 2 hours of talks, we'll be spending the last hour of the webinar in discussion with you. We'll start today by hearing from Dr. Katie Selzer, who will share with us about the DAC Healthcare System Preparedness Program. Please be sure to drop any questions for Katie in the chat. Thank you.
Available through our YouTube channel, and Dr. Govaya was kind enough to participate in our one this past June, if you would like to listen to that recording. We also have launched a blueprint. Thank you so much to Dr. Govaya for inviting me to speak today. My name is Katie Selzer. I'm the Medical Affairs and Scientific Communications Lead for the Davos Alzheimer's Collaborative Healthcare System Preparedness Team. I'm a neuroscientist by training. I spent about a decade working on Alzheimer's clinical trials and industry before joining DAC about 2 years ago. We've had the privilege of working with Dr. Bavaya as part of our early detection flagship program for the past several years, and just wanted to share a little bit of history about the Davos Alzheimer's Collaborative and share some updates on our new programs as well. So the Davos Alzheimer's Collaborative, or DAC, was founded in 2021 at the Davos meeting of the World Economic Forum. There was a number of previous public health initiatives, including Gavi and CEPI, in the infectious disease space that were successful at bringing together public and private sectors for a common goal. And so the purpose of DAC was quite similar. DAC was created as a private-public mechanism to coordinate and accelerate progress in the policy commitments around brain health and dementia. The DAC organization includes 3 programs. The first of those is focused on global diversity. We know that much of Alzheimer's research is based on a narrow subset of the population that is not representative of a global population. And so the goal of this program is to build a global cohort of high-quality data so that discovery of novel diagnostics and treatments, as well as better understanding of the disease, truly represents the global population. The second program is global clinical trials, whose focus is reducing the cost and time to bring new treatments to market globally. And the third program, and the focus of the presentation and work I'm going to talk about today, is all around healthcare system preparedness and making sure that patients and families have access to novel innovations, including diagnostics and treatments. So to give an analogy about healthcare system preparedness and the focus of our work, we like to think of new diagnostics and treatments as high-speed trains. However, healthcare systems are not prepared to support these new innovations and are working on antiquated tracks. So our goal is to help update the healthcare system so they can more quickly adopt new tools and treatments. We know from other areas of healthcare that there is a significant gap between the discovery of evidence-based interventions and widespread adoption. About 50% of the time, it doesn't happen at all, and the other 50% of the time, it takes about 17 to 20 years for new innovation to be used in clinical practice, which is a long time when you think of Alzheimer's and dementia patients. So the goal of the DAC system preparedness team is to catalyze healthcare system transformation so patients and families have quicker access to new innovations, and we're doing this using implementation science methods. The DAC system preparedness team has 2 broad approaches. The first is generating evidence of the barriers and facilitators to adopting novel technologies like digital cognitive assessments or a blood test. We do that through flagship programs and grant programs. So broadly, we're using implementation science to understand the barriers at the level of healthcare system operations, clinical medicine, and policy. The second activity is dissemination of all of our program learnings. It's really important to us that what we learn and the evidence that we gather is broadly accessible and applicable to others. So we do this through a variety of channels, including hosting community of practice with our site leaders to make sure they're able to share learnings and best practices in real time with each other. We also have biannual webinars called Learning Labs, where we'll take what we've learned in the field and make it accessible to a wide audience. These are recorded and available through our YouTube channel, and Dr. Bavaya was kind enough to participate in our one this past June, if you would like to listen to that recording. We also have launched a blueprint and a few new programs called System Fellowships, which I'll talk about in a few minutes. And then lastly, we also leverage a variety of media outreach and share our program learnings through peer-reviewed manuscripts and presentations at scientific meetings. The DAC System Preparedness Framework was developed in 2020 to help guide healthcare system transformation across the Alzheimer's care continuum, and we view this a bit as our North Star. The framework identifies 10 measurable nodes for us to help focus our implementation programs. If you want to learn a bit more about the framework, please feel free to take a look at that bullet all reference shown in the bottom right-hand corner. So in 2021, we launched our first implementation program on early detection of cognitive impairment. The early detection program had 2 approaches, both through flagships and grant programs. The flagship program shown with the red pins included 7 sites across 6 countries, including Jamaica, Mexico, Brazil, Scotland, Japan, and 2 sites in the United States. And all of these flagship sites shared a common protocol and study design. In 2022, we also introduced 12 global early detection grant programs because we knew the common protocol of the flagship would not necessarily apply or work in all regions, and we wanted to better understand how other healthcare systems would use tools and innovations in their own local settings. Flagship program, which included Jamaica as one of those 7 sites, The goal was to increase the rate of early detection of cognitive impairment in primary care. So through routine primary care visits or other non-specialty visits, the sites implemented a digital cognitive assessment. They would ask patients to complete tests for reversible causes if appropriate, and some sites also implemented a blood biomarker test as well. The endpoint of this study was having a cognitive assessment in the medical record, and we were also interested in understanding the facilitators and barriers of implementing the digital cognitive assessment in existing clinical pathways. Out of this flagship program, we co-designed an early detection blueprint with our site leaders over the course of 2 years. One of the key learnings was that physicians are largely incentivized to work in the practice, not on the practice. And when it comes to early detection in primary care, we know that there are a lot of operational and resource hurdles that sites need to navigate. So the program learnings from early detection were synthesized into a practical digital tool to hopefully serve as a resource for other healthcare systems seeking to adopt best practices in Alzheimer's care. Our setting leaders were incredibly engaged and persistent in addressing barriers throughout this 2-year program, and they found many smart and practical ways to solve challenges together. We wanted to be able to share these learnings and resources created throughout the program, and so they were built into this blueprint. The blueprint breaks down the process of an early detection program into granular steps. There's 3 main modules of the blueprint that include plan, implement, and monitor and evaluate. And then within each of these modules, there's a series of goals, actions, and resources that are helpful to others interested in implementing a similar program. The blueprint also includes a series of case studies from each of the 7 flagship sites. So if you want to learn more about their unique programs and key lessons learned, please be sure to check that part of the blueprint out as well. So we know that early detection of cognitive impairment is a critical building block for healthcare systems and helps identify the right patients for the right interventions at the right time. Since data collection of the early detection program ended about a year ago and we've launched our blueprint, we're now shifting our focus to dissemination. So starting in the US, we have a healthcare system fellowship program as well as a sister brain health navigator program. The goal of the fellowship program is to run the blueprint in 10 US healthcare systems and to better understand some of the unique challenges in the US. We also want to work with an additional 6 systems to develop training resources for brain health navigators, which we know are our key role, as we learned as part of our early detection program in several of the sites. Our hope is that if we build these fellowship programs in the US and understand the resources and capabilities needed to run them, we can then partner with national governments to run similar fellowship programs in other countries as well. So coming back to our framework and where we are today, we're disseminating learnings from the early detection programs. We've also launched our second global implementation program called Accurate Diagnosis, which includes 8 sites in 5 countries to further understand how to use blood biomarkers in primary and specialty care settings. We're also hoping to start a program in the public health space focused on consumer activation and awareness in the next year. And DAC is also participating in a 5-year EU-based program called 80 Riddle. And this program spans several of the nodes within our framework. So taking a look at our footprint today, it has really grown substantially in the past 3 years, with now 49 programs or sites across 18 countries. This includes our new programs of Accurate Diagnosis, the US Fellowship and Brain Health Navigator program, as well as 80 Riddle. And there's a number of ongoing catalyzed activity that has stemmed from the early detection program as well. If you have a chance and would like to learn more about any of our programs, please take a look at these QR codes. And you can find more information about the Accurate Diagnosis and 80 Riddle programs. There's a QR code there that links directly to the blueprint. And then for any announcements and more details about our other programs, there's a link in the bottom right-hand corner to our DAC website. Thank you so much for the opportunity to talk a little bit about our work at DAC. We have really enjoyed collaborating with Dr. Gobaya these past several years. She's a wonderful partner and advocate in this field, and really looking forward to hearing more about the Jamaica program learnings during this webinar. Thank you again.
And thanks so much to you, Katie. We've really enjoyed being part of the DAC family over these last years and are really looking forward to continuing to grow and learn with the wider DAC family. So now that we've heard a bit about the full DAC healthcare system preparedness program of work, we're going to start focusing a bit more on the early detection program. This is the program in which the flagship projects were situated. And we'll hear a bit about the Jamaica's adaptation of the common protocol that the flagship sites were expected to implement by our own Dr. Ariel Roberts. So over to you now, Ariel.
Good day, everyone. My name is Ariel Roberts, and today I will share with you about how the Jamaica site adapted and implemented the DAC Healthcare System Preparedness Early Detection Protocol to meet the needs of our participants and leverage our available resources. Firstly, a little background about myself. I'm a junior research officer with Amaji Health Limited. I'm also a medical doctor with over 4 years of experience working in the Southeast Regional Health Authority in Jamaica, as well as in private healthcare. Having completed observerships and externships in the Northeast US, I'm happy to be based in Jamaica again, in leadership roles such as being the rheumatic fever and rheumatic heart disease program coordinator for Kingston and St. Andrew. As a volunteer with the Ministry of Health and Wellness's Know Your Numbers campaign, I also provide screening services for non-communicable and communicable diseases and offer appropriate counseling and referrals. I'm passionate about preventive care and holistic health management, and so deeply appreciate being part of the work that we're talking about today. As Katie indicated, the DAC Healthcare System Preparedness Early Detection Workstream's flagship projects required that a common protocol be implemented across the 7 participating sites. 4 of these sites focused on the public health system and 3 focused on the private health system. 2 of the sites that focused on private health systems were in the United States, one in Florida, Advent Health, which is a Seventh-day Adventist health network which has locations in 8 other states in the US. The other, Indiana University, is a school of medicine and medical center. Jamaica was the 3rd site that focused on private healthcare. Around the middle of 2021, when the DAC flagship projects program was officially launched, the public healthcare systems in our Caribbean small island developing states were still managing the pandemic and its aftermath. Given the pressures on the public health system, the Jamaica site focused on the private healthcare system in our main metropolitan areas of the Kingston, St. Andrew, and St. Catherine parishes. As you can see from the figure above, the common protocol of the flagship sites had specific assumptions and interdependencies built in about typical services available. I'll share 5 key assumptions. One is that medical practice has an electronic medical record or EMR system in place. A second assumption is that in the EMR, there will be a baseline cognitive test score for all patients. A third assumption is that the annual wellness visits are part of the health system offering. In the US, these annual wellness visits are preventive healthcare visits focused on a patient's health risks, developing personalized health plans, and improving patient outcomes. A fourth assumption is that the health system has dementia registries. These registries collect standardized data on people living with dementia to help improve understanding and treatment of Alzheimer's disease and related dementias. A fifth assumption is that there is infrastructure and resources for clinical trials for research for diagnostics and treatments for brain health, and specifically for Alzheimer's disease and related dementias. All of the sites implementing the common protocol were invited to select the digital cognitive assessment platform that they were going to use from among several companies which offered access to their platform and related customer support for the duration of the flagship project. All of the sites also had available access to a blood-based biomarker test called the Percivity AD test, developed by a specialty diagnostics company called C2N. The blood biomarker test is meant to assist with the accurate diagnosis of Alzheimer's disease, as it detects beta amyloid plaques in the brain, one of the hypothesized disease mechanisms for Alzheimer's disease. All of the sites were expected to interview doctors directly or indirectly, and Doctors directly or indirectly involved in the administration and or review of cognitive tests with patients 60 and older at both baseline, that is, before or at the beginning of the period during which the patients took the digital cognitive assessments, and at endpoint, which was expected to be after the collection of the blood-based biomarkers. To facilitate a scope and design in Jamaica that was context sensitive, Dr. Ishtar Govaya leveraged her existing roles and projects. Specifically, when Dr. Govaya was first approached about the DAC initiative in January 2021, she was leading a team in the final year of another grant-funded project called Strengthening Responses to Dementia in Developing Countries, also known as STRIDE. She leveraged the research infrastructure and stakeholder relationships that were developed from this, and other related projects in Jamaica to understand what was going to be doable in the Jamaican context, what would likely not work, and what types of adaptations would be needed. Ishtar was then the chair of the board and the managing director of the Jamaica Mental Health Advocacy Network, known as JAMHAN, and this became the organizational home for Jamaica's flagship project's implementation. As anyone who has been involved in research project knows, ethics approval and contracting between entities are typically elements of the project setup period that take the longest. This was indeed the case for Jamaica's flagship project. The contract was fully executed in June 2022, and ethics approval was obtained in December 2022. During the interim and before fieldwork could officially begin, Dr. Govaya and the team engaged in ongoing discussions with stakeholders to ensure a scope and a design in Jamaica that allowed an implementation and reporting cycle that would be as efficient and as effective as possible, as well as have the strongest buy-in. The project setup period included recruiting and training research team members, refining the protocol, and conversations with stakeholders to understand their physical spaces, typical workflows, and available personnel and technological resources. 2023 was the year for the Jamaica site fieldwork and data management. The digital cognitive assessments data collection occurred between January and June 2023, and the blood tests and ECGs for reversible causes of cognitive impairment occurred between June and October 2023. Data management was ongoing, and by November 2023, the de-identified data set was transferred to the Alzheimer's Disease Data Initiative AD Workbench platform. These data included the baseline and endpoint qualitative and quantitative interviews with the medical doctors and the quantitative data from 743 participants who completed digital cognitive assessments. Given the differences that the Jamaican context offered in terms of non-existent clinical trials infrastructure, no dementia registries, variability in the use of electronic health records, and the general absence of baseline cognitive testing for persons 60 and older, one of the key adaptations that the Jamaica site made was switching the focus from early detection to timely detection. Early detection in Alzheimer's disease and related dementias refers to pre-symptomatic and mild cognitive impairment stages. Timely detection, on the other hand, focuses on when concerns about cognition, behavior, or functioning are apparent to the person experiencing it, or to a clinician or a caregiver. As there is no annual wellness exam routinely offered, the Jamaica site also focused on recruitment of any person 60 and older who presented at any of the 8 primary care practices or 1 specialist medical practice and did not have a previous diagnosis of Alzheimer's disease. As Catherine will discuss, 14 consented physicians located at these primary and specialist practices underwent a sensitization session on the study's diagnostic procedures and received an overview of Alzheimer's disease and related dementias. Among the practices included, only 7 used electronic health record system. The majority used traditional paper-based record keeping and filing system. It is important to recognize that the patients who go to see their doctor in primary care settings in Jamaica are typically going for a specific health concern versus for preventive care. This, as you will hear from Janelle's talk, has implications for the patient profile that we had in Jamaica. In addition to the medical practices, recruitment also occurred at 23 events coordinated with community partners, such as health fairs and specially organized sessions with voluntary organizations and places of worship. As you see from this figure, the Jamaica site did not collect blood-based biomarkers. This was because the export license needed to send the samples to C2N's US lab for processing and analysis could not be obtained in time. From the visits to potential medical practices and the discussions with the doctors during the project setup period, it was clear that the doctors and their practice personnel were stretched, and while interested in the concept of administering the digital cognitive assessment, were unlikely to administer it themselves. At the Jamaica site, it was therefore the research officers who administered the digital cognitive assessment, acting as brain health navigators, which we will refer to as BHNs, as opposed to personnel who were part of the medical practices. These BHNs coordinated data collection days with practices and community partners and were stationed at healthcare practices and community sites on agreed upon days or via scheduled appointments with individual patients. For the tests for reversible causes of cognitive impairment, the BHNs worked with a medical lab franchise that had branches in Kingston and St. Catharines, to offer the blood panels, and with a private hospital-based cardiovascular center for the ECGs. For any patients who received a screening result indicating borderline cognitive impairment or cognitive impairment, they were advised that they were eligible for fully subsidized tests for reversible causes of the detected impairment. The BHNs completed the collection of DCs between January and June, and in June started the scheduling of patients for the blood tests and the ECGs. Although it would have been ideal to have sent the relevant patients immediately for the blood tests and ECGs, the scheduling for these tests started later because of the limited team time to manage these logistics alongside other competing tasks. As Katie noted, the lessons learned and adaptations that each site made for the flagship project informed the development of the free online tool called the DAC Blueprint that helps healthcare systems develop programs for detection and management of cognitive impairment. The blueprint provides strategies that fit into one or a combination of three approaches. The first is a top-down change approach, where governments lead the development and implementation of the program. The second is a bottom-up approach, where change starts with a smaller unit, such as clinics in a specific administrative district. The third, a hybrid approach, leverages the momentum from a local program and the interest and influence of government to creating sustainable health system changes. The blueprint is organized into three key modules, further divided into sections which each have a series of goals. Each flagship site provided key lessons learned which were aligned with at least one of the goals. As you'll hear from Catherine, one of the key lessons from the Jamaica flagship site was to create pathways for people to get into the healthcare system. Jamaica was the only site which secured additional funds to subsidize the tests for reversible causes of cognitive impairment. This was a crucial intervention for the Jamaican context, as such a high proportion of these patients screened as cognitively impaired or borderline for cognitive impairment, and you'll hear more about that in Janelle's talk shortly. Beth's talk will highlight another key lesson from the Jamaica flagship site, which is about the benefits of task shifting from medical doctors to the research team and having the research team members function as brain health navigators. A third key learning from the Jamaica flagship was about the critical role that community partners play in awareness raising and public education around Alzheimer's disease and related dementias and brain health more generally. These relationships were ones that Ishtar and the rest of the team built over several years. They are relationships that focus on co-development of solutions that are most meaningful to the community stakeholders. Overall, the Jamaica site adaptation was one attentive to the realities of the healthcare system in Jamaica. It prioritized task shifting to facilitate additional services in the least obtrusive way in the participating medical practices. It co-develops with the community stakeholders opportunities for providing the DCAs at events and locations where they would be most useful. Finally, it offered fully subsidized services that the patients would otherwise not have been able to experience. It is because of these adaptations that the Jamaica site was able to garner the insights from the patients that Janelle will speak about next. Thank you for listening, and please do share any questions and any comments that you may have.
Thank you so much for that presentation, Ariel. We heard a lot about how we managed to adapt and adjust and iterate over the course of the time that the flagship project took us to undertake in Jamaica. A number of you in the chat have asked about whether the assumptions that were built into the common protocol held for Jamaica. And hopefully, now that Ariel's presentation has ended, you've heard from us that indeed we did realize that a number of these assumptions were not valid in our Jamaican context. And so we really needed to make special adaptations. We needed to figure out how to make a protocol work and what were the essential ingredients and which were the optional ingredients. Thankfully, the DAC family was very open and receptive. And as we've shared with you, we're also able to facilitate additional resources for us at the Jamaican context. For example, the subsidization of the test for reversible causes, as that was one of the key insights that we got very early on, that even though patients were advised to go to get additional testing, they actually could not afford it. And so that additional testing would likely not have occurred were it not for the subsidization. And you'll hear more about that in some of the other talks today. So as we continue, I'll now be passing you on to Janelle Robinson, who will share about the patient story. This is where you'll hear a bit about the profile of the participants who completed the digital cognitive assessments. Over to you now, Janelle.
Hello, everyone. I am Janelle Robinson, researcher and associate clinical psychologist. I'm also the senior research officer here at Amaji Health Limited. We will be delving into the patient story, specifically describing the cognitive health profile of Jamaicans 60 years and older who participated in the Davos Alzheimer System Preparedness Study in Jamaica. But firstly, let me share a little about me. I have a diverse career spanning banking, mental health, and research. With over a decade of experience in the mental health sector, I have served as a researcher, clinician, and research coordinator. I have led innovative programs and public awareness campaigns with nearly 20 media appearances and extensive corporate training sessions that have raised awareness on vital issues such as mental health, domestic violence, the impact of COVID-19 on one's mental health, and of course, Alzheimer's disease and related dementias. In the past 5 years, I have led key work packages under multi-country research on dementia in Jamaica, engaging stakeholders, including senators and psychiatrists, and also exploring culture-specific stigma and the socioeconomic impact of the disease. My expertise is further highlighted by my leadership in mixed methods research, mentoring global researchers, and authoring over 14 peer-reviewed articles. Currently, I serve as both the senior research officer and team lead at Amaji, and have been a team lead on multiple ADRD projects in Jamaica, including the DAC flagship project, which really underscores my commitment to advancing dementia research and care. I've also presented at esteemed conferences such as the International Society for Traumatic Stress Studies and the Alzheimer's Disease International Conference. Also, as a research consultant, I have worked with the European Union, World Bank, and Wellcome Trust. But enough about me. For today, I'll begin by comparing the cognitive health of older persons in our study to those from other countries participating in the DAC study. I'll then provide an overview of the patients who participated in this study and their cognitive health status. Next, I will discuss how cognitive impairment is distributed among the patients, focusing on key demographics like age, gender, and other relevant factors. We'll then explore how lifestyle factors, as reported by the patients themselves, are related to cognitive impairment status. And lastly, we'll look at cognitive impairment related to medical conditions that can potentially be treated or reversed. So how did Jamaica perform compared to the other countries? In terms of absolute numbers, Jamaica, being a low to middle income country, has shown one of the highest numbers of cognitive impairment in the study when compared to higher income countries like the USA, Scotland, and Japan, and even other low to middle income countries. Specifically, and again, in terms of absolute numbers, Jamaica had the highest number of patients screening for borderline impairment. And among those with abnormal impairment, we had one of the highest proportions. Let's now take a look at the patient profile and cognitive screening results. In total, 743 patients, all aged 60 years and older, were included in the study and given digital cognitive assessments between January and May 2023. Most of the patients identified as women and were between the ages of 60 and 93. On average, participants had about 11 years of schooling, which is roughly equivalent to completing the 11th grade or 5th form in Jamaica. The distribution of the patient's cognitive health showed high rates of impairment, with over 80% of the participants having signs of either borderline or full cognitive impairment. Specifically, looking at the chart here, 46% had signs of borderline impairment, highlighted in yellow, and 40% had signs of full cognitive impairment, highlighted in red. Now let's take a closer look at how cognitive health varies by age and gender among our participants. Similar to the overall distribution, both men and women showed high rates of either borderline or cognitive impairment, with women having slightly higher numbers. The graph here shows this difference very clearly. However, when we examine the data more closely using statistical analyses, we found that these differences were not significant. This means that even though the numbers might look different, the overall level of impairment is very similar between men and women. In practical terms, there isn't a meaningful difference between the genders in our sample. Now let's take a closer look at age. We grouped participants into 5 years intervals, and we found that those who performed cognitively normal were mostly in the younger age range. So almost 70% of those in the normal cognition category here were between 60 and 70 years old. For the borderline category, you can see that as age increases, so too does the proportion of those in this group. There's a noticeable rise in the borderline category for people aged 70 to over 80 years old compared to the cognitively normal group. As we move to the impairment category, you can now see a consistent pattern. As age increases, so does the likelihood of cognitive impairment. 60% of those individuals within the impaired category were over 70 years old, while most of those in the normal category were younger than 70. Overall, within our sample, as people get older, their level of impairment tends to significantly increase. Let's now look at the lifestyle risk factors according to cognitive health. We assessed various factors to help providers understand a patient's current cognitive status and their future risk of dementia using the Linus 32-item Life and Health Questionnaire. Following completion of this questionnaire, the report gives you a sense as to where the patient is doing well and what areas need more attention. For example, this patient, male, 77 years old with 16 years of schooling, is doing well with his diet, mental health, and learning new things, but needs to focus on his physical health, social support, sleep, and daily movement. Let's now take a deeper look in terms of the domains captured by the 32 items of this questionnaire. We looked at several areas, including lifestyle choices, so things like diet and exercise. We also looked at mental, emotional, and social health, so looking at anxiety and depressive related symptoms. We also looked at medical conditions like diabetes, hypertension, vitamin deficiencies, and head injuries. We also considered sensory issues like hearing, olfactory, and vision problems. And also we looked at the overall quality of life. In total, there are up to 32 possible risk factors that our patients could report. So let's see how the patients actually performed. Most of our patients reported at least 8 risk factors. About 34% had fewer than 7 risk factors, while over 66% had more than 8. When we looked at risk factors by cognitive impairment, as shown here on your screen, the group with normal cognition had the fewest risk factors. In contrast, those in the borderline and cognitively impaired groups had many more risk factors, with some reporting over 16, as shown in the orange bar of this chart. The third in the grouping is very concerning. And this is concerning because we know that addressing lifestyle choices is crucial for reducing the risk of cognitive impairment. So what are some of the specific risk factors being reported? Overall, our sample had high rates of medical and physical conditions, as well as sensory challenges. The most common issues reported were vision problems, hypertension, diabetes, and hearing problems. And just to point out, hearing and vision problems, as well as serious head injuries, varied significantly across the different levels of cognitive impairment. Notably as well, the borderline and impaired groups had much higher rates of these conditions compared to those within the normal cognition group. Overall, high rates of medical and physical conditions were very evident within our sample. Another important area to highlight is the mental and emotional health risk factors. The borderline and impaired groups reported significantly higher rates of loneliness or lack of social support, frequent feelings of loneliness, anxiety, or worry, and current treatment for depression or anxiety. And these are known risk factors for Alzheimer's disease and related dementias. We saw how social isolation affected older adults with ADRDs during the pandemic. And though this is a topic for another presentation, it is very crucial to highlight these results from our sample. In addition to the self-reported lifestyle and health risk factors that we just covered, we also conducted objective assessments for other known reversible causes of impairment using blood tests and ECGs. For individuals who screened positive for some form of impairment, we offered fully subsidized tests to identify reversible causes of mild cognitive impairment. However, due to non-responses or refusals, only a subset of these individuals completed the tests. In total, between June and October 2023, 361 individuals underwent between 30 and 40 different blood tests. These tests included metabolic panels, thyroid panels, infectious disease panels, lipid panels, liver function tests, diabetes screenings, vitamin panels, and complete blood counts. And these panels are based on known rule-out causes of cognitive impairment. Nearly 100% of those who had blood tests showed some abnormalities, meaning their results were either above or below the normal range. Only 2 patients of the 361 had results within the normal range. And looking at the distribution of the results here on your screen, for those who had abnormal findings, we see that about 51% had 1 to 5 abnormal results, 47% had 6 to 10, and nearly 2% had up to 15 abnormalities. I want to highlight specific panels that are relevant to today's discussion, starting with the diabetes panel, particularly the glycosylated HbA1c and the glucose levels. Nearly 65% of individuals had elevated HbA1c levels, indicating high rates of diabetes or poor blood sugar control. And this is concerning because elevated HbA1c is a key marker of long-term blood sugar issues and a significant risk factor for cognitive decline. Similarly, in the vitamin panel, over a quarter of those tested had abnormal vitamin B12 levels. When you don't get enough vitamin B12, it can lead to problems with how your brain works. This deficiency can cause memory problems, confusion, and difficulty thinking clearly, all of which are signs of cognitive impairment. Looking at the thyroid panel, over 4% had abnormal levels of thyroid stimulating hormone. Abnormal levels of this hormone can affect brain function. For example, an underactive thyroid can cause memory problems, difficulty focusing, and slow thinking, whereas an overactive thyroid can lead to anxiety, restlessness, and trouble concentrating. Looking at the lipid panel, and just to highlight a few areas, nearly half of the individuals had high total cholesterol, and a quarter had high levels of LDL, which is also called the bad cholesterol. And this increases the risk of heart disease. Around 18% had high triglycerides, which is another risk factor of heart disease. Additionally, approximately 16% had an elevated risk ratio, which shows a higher risk for cardiovascular problems. Overall, these results indicate that many individuals within our study are at risk for cardiovascular problems, which can also impact cognitive health. Looking at the metabolic panel, specifically the creatinine levels, over 80% of individuals had elevated creatinine, and this is concerning. And of course, we would examine these levels in the context of other metabolic-based tests conducted. Nonetheless, and just to point out, high creatinine can indicate potential kidney issues, which may affect overall health and cognitive functioning. Just to highlight as well, when we compare the borderline and impairment categories, both groups showed similar levels of abnormalities across the various panels conducted. Let's now turn our attention to our ECG results. ECG data was collected between June through October 2023 from a subset of individuals who also had blood tests. We found that most of our patients had abnormal ECG results, with those within the cognitive impairment category having more ECG abnormalities compared to those within the borderline impairment category. And just to highlight key abnormalities found, some patients had abnormalities relating to sinus bradycardia, which may be an indication of slow heart rate, and is sometimes linked to other issues like first-degree AV block, which is also seen here. We also found abnormalities relating to the left ventricular hypertrophy, and this abnormality can be related to conditions like high blood pressure or heart issues. Abnormalities were also found relating to non-specific STT changes, as well as the right bundle branch block. All of these is an indication that further assessments needs to be undertaken. These ECG abnormalities, along with the blood panel results, suggest that there are factors that might be contributing to cognitive impairment, with many of these are either treatable or reversible, and addressing these could help to manage or even prevent further decline. What does this all mean? Specifically, many patients in our sample are dealing with unaddressed and, in some cases, unknown levels of cognitive impairment. In fact, over 80% of our sample had cognitive issues. We also found that many of our patients are coping with comorbid challenges that they and their primary care physicians may not be aware of. We saw in our study that in addition to the self-reported medical and mental health conditions, the borderline and cognitively impaired categories had similar levels of abnormalities in their blood and ECG results, suggesting that timely intervention, leveraging tech-enabled resources, can increase the reach as well as timely detection and treatment of these individuals. Additionally, many of these abnormalities indicate potentially high cholesterol, elevated blood sugar, or vitamin deficiencies, which are all potentially either treatable and some being reversible. This truly offers some hope for intervention, as addressing these issues could slow or even prevent further cognitive decline. Relating to our point 3 here, we observe that cognitive impairment significantly increases with age. And finally, our study is the first of its kind in Jamaica. Through the leadership of Dr. Ishta Gavayo and the DAC team, our data is offering crucial insights into the cognitive profiles of individuals and highlighting potential contributing factors. It's a first step in understanding and addressing cognitive impairment in our population. It further highlights the importance of timely detection and management to potentially improve outcomes and reduce the risk of worsening impairment. I would like to thank you for listening, and we look forward to discussing how we can truly address these findings in upcoming workshops. Thank you.
Thank you so much for those insights into our participants, the patients who completed the digital cognitive assessments. Thanks so much, Janelle. Those insights were crucial, and our research officers, our brain health navigators, were crucial in working with the participants, as you will hear from Beth's presentation in a bit, and also learning about what were some of these risk factors. Some of them that Janelle spoke about just now, vision, hearing, these are problems that they were able to actually detect. We know that these types of challenges can impact, for example, how someone performs on a cognitive assessment. And so these are factors that's important for us to think about. What do fit for purpose solutions look like in our context? If we have such a high proportion of our persons who are 60 and older who are living with unmanaged vision problems or vision problems that are worsening, are living with hearing problems, and in some cases we realize that these were not necessarily permanent hearing problems, but they could have been something simple, like many of them had impacted wax, for example. We discovered this in our partnership with MobiCare, which is a mobile health provider. And these are the types of risk factors, the high cholesterol, the high blood pressure, which if they are untreated, if they are unmanaged, they can really exacerbate and lead to a progression to Alzheimer's disease or related dementias. So these insights about our patients in our sample are really important in terms of understanding what might lead to dementia later on, what are risk factors, and what is really within our control, our power and our control to manage. So now that we've heard a bit about the patients, we're going to hear now about the doctors who were crucial in implementing the Davos Alzheimer's Collaborative flagship project. So we're now going to hand over to Catherine so that she can share the doctor's story.
Hi, everyone. My name is Catherine Brown, and I'm happy to be here to present on insights from participating Jamaican healthcare professionals of the DAC study. The purpose of this presentation is to highlight participating doctors' description of the current care pathway in Jamaica and their challenges in implementing early detection measures and managing care of Alzheimer's disease and related dementias, as well as their perspectives on the possibility of improvement. But before I begin, I just want to briefly introduce you to the person who will be taking up the next 25 minutes or so of your time. I am a senior research officer with Imagi and have worked with the team who now make up Imagi for almost 2 years. I've been involved with data cleaning and analysis for this DAC study. I am Bahamian by descent, but have resided in Barbados for over 20 years now and have been a research associate with the University of the West Indies George Allen Chronic Disease Research Centre for about 10 years. I also lecture part-time for the Faculty of Medical Sciences at Cave Hill campus here in Barbados. And most of my research experience is in managing data collection, systematic reviews, and qualitative research, working with teams from the UK, North America, Pacific Islands, and the Caribbean region across multi-sectoral international grants. While most of my work has focused on nutrition and food security, mental health has always been a passion of mine. I focused my master's in public health project on dementia caregiving back in 2014, and I'm also currently pursuing my PhD in public health on the relationship between diet and mental health in the Caribbean, also with the University of the West Indies. In addition to becoming a student again and my current research work, I'm a mom of 2 young girls and an animal lover with 3 rescue dogs and a new kitten that has recently found its way into our yard and adopted us. So enough about me. Let's see what we're going to be looking at in this presentation. So I'm going to summarize for you the characteristics of participating healthcare professionals of the DAC study, their reported current evaluation process for Alzheimer's disease and related dementias, or ADRD, as I will say throughout this presentation, their reported challenges to the care pathway for patients with ADRD, their suggested building blocks for an improved care pathway, and finally, the impact of the DAC study on these healthcare professionals. So let's begin with the participating healthcare professionals, the doctors. Of the 18 doctors who consented to participate in the study, 14 ended up actually participating and took part in the short quantitative survey, which I'll get to later on in the presentation, and 12 participated in our qualitative interviews. Both of these were conducted before and again after the study. For the survey, 10 participants were male doctors and 4 of them were female doctors. These same persons participated in the interviews, except 2 of the female doctors. The participating doctors were practicing medicine between 4 to 44 years, which averaged out to about 25 years. So these were senior and seasoned GPs. The doctors came from 7 different clinics. 10 of them were primary care doctors, or those who work as GPs, and 3 were specialists in endocrinology or internal medicine. The interviews were extremely helpful in understanding the usual care pathway that doctors took when seeing a patient with possible cognitive impairment, with some aspects showing considerable variation between doctors and others being quite standard. So let's walk through this process together. At presentation, doctors noted that patients presented at variable stages of decline, some early, some middle, moderate, and some late stages. But mostly they were moderate or late stages. And this largely was reliant on the patient's family, who encouraged him or her to visit the doctor or took them themselves. Though in some cases there was self-report from the patient, who reported that their memory was not like it used to be, or that they were concerned about some lapses. At the start of the diagnosis stage, as I just mentioned, the patient history was a mix of self-report of their own complaints, or they were accompanied by a family member who was also able to share the patient's history. One area where we found considerable variation between doctors in this evaluation process was the choice of cognitive screening done. Now, some tests were completed electronically on a computer or tablet, while others were done with a pen and paper. Some used quite standardized tests like the mini mental state exam, while others used a simple clock drawing test. Some selected a cognitive test by a Google search of whatever comes up online, and some did no actual test at all, but instead used their own clinical intuition to judge. However, when we look at tests of reversible causes, the reported blood tests were very similar and included, for instance, vitamin B12, thyroid tests, VDRL for syphilis, liver, calcium, magnesium, HbA1c, etc. Yet there was some variation when it came to neuroimaging on whether the doctor requested an MRI or a CT scan, or if they left this for the referred specialist instead to make that decision. So let's talk about the referrals. We found considerable variation in the referral process. When to refer depended largely on the level of confidence of the primary doctor, and most seemed to indicate reluctance to diagnose and treat on their own due to self-reported inadequate experience in this particular field of ADRD. And who to refer also varied and included psychologists, psychiatrists, and internal medicine specialists and neurologists. However, most highlighted that the limited number of specialists in Jamaica, especially neurologists, meant that sometimes they avoided going through the public system at all or seeing a neurologist at all, as they knew there would be an inordinate length of time for the patient to actually see a doctor and get a test done. Despite this, there was a general sense of preference to refer to specialists, as they felt that specialists were more equipped than themselves with the skills and knowledge in diagnosing ADRDs. And arguably the most significant, where we found no variation, was that all interviewed doctors indicated that they did not do routine cognitive screening of their patients. Cognitive screening was only done if a complaint was raised by the patient or his or her family, or if, in some cases, a symptom appeared by chance during the visit with the doctor, where the doctor subjectively flagged it him or herself. For instance, if the patient seemed a little bit off, maybe the patient had a new speech impediment, had a different behavior personality, or forgot things they had in the conversation. So now that we have a sense of the evaluation process for these doctors, let's talk about the challenges they face. When analyzing challenges regarding healthcare for ADRD, we were able to categorize doctors' perceived challenges at 3 different levels: the patient level, the physician level, and the wider system this all sits in. We also found some challenges which were cross-cutting over all 3 of these levels. And while I'm going to go ahead and discuss these separately, these different levels, I do want to highlight that these challenges are not operating in silos. They not only occur simultaneously, but they seem to impact one another, creating a web of feedback loops. So let's start at the individual level, the patients. First, we have financial constraints. Doctors indicated that patients at the lower end of the socioeconomic scale are less likely to have private insurance and more likely to rely on the public healthcare system. These patients in the lower socioeconomic group who are in the public system are, first, more likely to have longer wait times for appointments with specialists and for neuroimaging testing. And second, they're also usually the patients that tend to not follow through with testing and treatment. Doctors often mention that they consider the patient's family network when determining their care plan, and if there are family members who live overseas, some may suggest whether they can assist the patient in accessing or paying for the services in the private healthcare system in Jamaica. And as you can see from this quote, that supports that. Also reported were competing health priorities. Given the long wait times, doctors noted that patients who had comorbidities such as diabetes or hypertension or other illnesses were more keen to report and seek attention for these conditions rather than the cognitive impairment they might be facing. Cognitive impairment was often placed at the bottom of their list for investigation. As we can see from this quote, cognitive impairment is not as seen as dramatic a condition, in the early stages at least, as other more physical-based, non-communicable diseases may seem to be. And finally, we have our sociocultural factors at play. For instance, there was mention of the cultural preference by some for more religious and natural remedies over clinical medicine. And I think most doctors are aware of the gender disparity in healthcare, where males are usually less likely to access healthcare services. And this was mentioned briefly without explanation as to why, but research has shown this to be because of their fear and the societal norm of machoism in men. Now let's move on to the physicians themselves. What challenges are they facing at their own level? Oops. One strong theme that emerged from the data was insufficient training, and therefore lack of confidence of the typical primary doctor in treating ADRDs. Now, we touched on this earlier when I spoke on the evaluation process slide. Doctors noted little focus on these conditions during their medical school training, especially older doctors who graduated many years ago. And the majority of their experience in this area largely depended on outside learning events such as dementia-specific continuing medical education sessions or other such workshops. And further, the decision to attend the events or to look more into the literature in this area on their own time often depends on the individual doctor's personal interest in it. Not all doctors seem to have a firm grasp on these cognitive tests, which one to use, when to use them, and even one doctor in interpreting the test results. This lack of confidence then is thought to lead to doctors feeling somewhat uncomfortable, perhaps even avoiding evaluating the signs and symptoms altogether, so that they end up focusing only on what they do know, such as the diabetes or the cardiovascular problem at hand. Or if something is very clearly noticeable or a complaint is presented, there is a preference, as I said, to refer to a specialist from the get-go. And then we have time. When it comes to the theme of time, this was depicted in two ways. First, the short duration of appointments with patients, and second, little personal time for self-education and training. Doctors greatly stress their struggle in managing crowded waiting rooms and difficulty in giving the necessary and sufficient time for patients. And overall, not just those with possible ADRD. And the probing and the screening processes required for possible ADRD was considered time-consuming and thus came second to other conditions being presented, such as high blood sugar or hypertension. And the lack of personal free time and perhaps interest also was an issue in that doctors found it difficult to attend continued medical education in this topic. So with these two factors alone, lack of training and lack of time, we can begin to see and appreciate a bit more why doctors don't routinely do cognitive screening on their patients. And finally now, let's talk wider picture. Doctors also described various challenges within the wider healthcare system that prevented them from providing optimum care for patients with cognitive impairment. Now, what were these challenges? Limited infrastructure and specialist care. For instance, it was noted that beta amyloid screening is not offered in Jamaica to help diagnose Alzheimer's disease. Doctors lamented that there were few MRI machines with long wait times for an appointment and very few neurologists, which take months to get an appointment with. Doctors attributed the poor follow-up in the public sector to these very issues. Two doctors even noted that they do not refer patients to neurologists at all because the wait times are just too long. They instead refer to psychiatrists if they needed to. And we also have inadequate care continuity. Some doctors describe the difficulty with continuing care with patients due to clinic processes, explaining that it was difficult to follow up with a patient whose tests were ordered because either the patient may see a different doctor when they return, that is, whoever happens to be on duty at that time, and doctors are also rotating between different clinics, making this even more difficult. And finally, it was noted that some specialists do not communicate with the primary physician who referred their patient to them in the first place to update them on the patient test results. So as this doctor said, you're just kind of out in limbo with what's happening with the patient. And yes, high costs and insurance coverage, limited insurance coverage, I should say. I touched on this somewhat in the patient-specific challenges. Doctors lamented that the public health system does not cover important investigations required to manage cognitive impairment, such as neuroimaging, specifically requested as a test for cognitive decline, nor medications for ADRDs. They noted that the private system is more accessible, yes, but only for those who pay out of pocket or have private insurance. And neurologists were noted to be the most expensive specialists. And finally, government competing interests. Doctors describe a notable lack of national priority for dementia to guide them in their work. For example, they noted that there does not exist a national guideline for diagnosis or treatment of ADRDs. And they also noted that tests for ADRDs and its medications are not covered by national health insurance. But I should note that this was not necessarily expressed in a negative way per se, but more pragmatically in that they appreciated that funding needs to be prioritized to conditions that have a high burden in the population and that are more objectively diagnosed and treated, such as diabetes and hypertension. So putting it all together, we see there are significant barriers to break at multiple levels. But on top of what I've discussed, we cannot forget key cross-cutting barriers that emerge from these interviews as well, including lack of knowledge. As for doctors, we touched on how impactful their medical training is on their current knowledge base and continued interest in pursuing further knowledge on the topic of dementia, which in itself affects the wider public and healthcare system. If the doctors themselves are not recognizing this condition, then how can the policymakers, or better yet, the patients that they're advising on, be recognizing it? And connected to the knowledge and priority given to cognitive health, there is an added layer of stigma associated with ADRDs, which led to patients avoiding seeing the doctor at all or refusing to do any tests, whether cognitive screeners like questionnaires, blood tests, or neuroimaging tests for reversible causes. One doctor mentioned that he avoids using the term dementia altogether with his patients, saying instead, changes in the brain affecting your memory, for example, to avoid the likely stigma, the possible denial and grief, etc. Though one doctor was an outlier in this, reporting no resistance by the patient and his or her family with the dementia diagnosis, and was comfortable using the specific term dementia. Though he also reported that his patients usually did present in the later stages of the illness, where symptoms are clearer and thus less of a shock to families. And what compounds this stigma even more is underlying ageism, where doctors might look at an older person with cognitive impairment and consider it to have less value in deeply investigating and treating than, say, another person or another patient in the waiting room who's waiting to be seen that has a myriad of other more, in their eyes, treatable conditions and therefore have a greater impact. Doctors report that perhaps the wider public may not see the worth in putting attention or funding towards ADRDs that affect more older individuals who are seen as less valuable or less able to contribute to society at this later stage in their life. Now, having gone through all these challenges that emerge from our conversations with doctors, we want to also know, more importantly, what can we do about it? Can we overcome them? And if yes, how? Otherwise, what really is the point? The doctors also shared some information on this next step, and this is where we really want to sit down and perk our ears. Despite the notable barriers doctors share that the burden of dementia is not going away and only getting worse. As populations age, they're seeing more and more patients with cognitive decline. They know they cannot stop this on their own, and the DAC study provided a renewed or new sense of hope and motivation for change in the healthcare system in Jamaica with respect to dementia care. And doctors were enthusiastic to be part of this next step. Doctors also believe that if disease-modifying treatments for Alzheimer's disease were to become available in the near future, as is anticipated with recent evidence, the care pathway for ADRDs will evolve and adapt. While they admitted it would take years, this potential new treatment could lead to a few things. One is increased demand from the public to access this drug, increased push from pharmaceutical companies to sell this drug, and eventually national and private health insurance would expand their coverage with the help of efficacious research data and lobbying from doctors. And so national interests will prioritize cognitive health more, especially as they see the growing burden on the aging population and perhaps even their own friends and family. Guidelines can be produced and the healthcare capacity, tools, human resources can be expanded. And this revamped care pathway is envisioned, for example, as having the primary care doctor screen and do all the tests, cognitive screening, tests for reversible causes, including neurology. He or she will then explain the results to the patient and then refer the patient to a specialist for full diagnosis and treatment. One doctor even went so far as to suggest that the primary doctor give the final diagnosis and prescribe the medication, and only see the need to refer to a specialist if there seems to be no improvement afterwards. Doctors also gave suggestions for key building blocks for a healthcare system that is supportive of this dementia care. So let's have a look at these. These reported building blocks include committed doctors, doctors who will recognize the unavoidable burden that we are facing, doctors who will lobby for an improved healthcare system and who will use available tools and treatments for the condition. Some suggested having someone else, perhaps a nurse, getting the patient to do the cognitive screening test while waiting before the visit to save time. Continuing medical education and drug reps will need to join the forces also to provide more knowledge and dissemination to boost confidence in doctors to recognize, diagnose, and treat patients with cognitive decline. Cognitive impairment, sorry. And at least in the early stages, doctors suggested the use of reinforcements or reminders for doctors to encourage them to do the cognitive screeners routinely. They suggested using incentives or reminders during patient visits, and this is particularly helpful, especially given their time constraints previously mentioned. Alternatively, these reinforcements could be that other staff members conduct the test for them, given the time crunch that they're facing. Media and health promotion would also be vital to show the need for prioritizing cognitive health and the effectiveness of new tools and treatments, especially showing success through data developed from countries, through data from developed countries, sorry. In fact, references to developed countries' success was mentioned several times. And also, very importantly, the media and health promotion would be necessary for desensitizing the dementia altogether, the term dementia and the idea of it. Nationwide campaigns, for example, to increase public awareness of the term, understanding its symptoms, causes, and treatments, how common it is, and importantly, that it is not a normal part of aging. This can in turn help with increasing patient social support in that more laypersons are able to recognize symptoms of cognitive decline, ensure the patient is transported to the doctor and follows through with testing and treatment. The establishment of specialized centers for ADRDs was also suggested, either whether it's public sector or private sector, where appointments can be scheduled ahead of time to give time for cognitive screening tests. And it was noted that patients prefer or gravitate to specialists anyway, so this specialized center could increase patients' confidence in test and treatment plans as well. Then, accompanied by lobbying from doctors, insurance coverage will need to be expanded to include testing for cognitive impairment and increased access to effective medications that are on the market. And finally, a committed and receptive government who can accept the growing burden of ADRDs and that change is needed. It was also noted several times that when a condition affects a politician, be it their family member or even him or herself, this personal affliction could help with a political play, so to speak, to bring ADRDs more to the forefront of their agendas in the healthcare system. So to sum it all up, all these pieces could very well create a healthcare system environment that is more socially and financially accommodating of ADRD screening, diagnosis, and treatment, therefore reducing its negative impact at multiple levels, be it patients, families, community, or nationally. Now, before I wrap up, I do want to share the doctors' reported impact of having participated in the DAC study. I mentioned earlier they completed a survey at the start and the end of the study. And it was called the General Practitioner's Attitude and Confidence Scale for Dementia, or GPACS-D. It's a short survey that was used to assess doctors' attitudes and confidence in detecting and managing cognitive impairment. The survey looked at 3 constructs, which you can see at the bottom of the screen on the x-axis. Looking at confidence and clinical ability scores, doctors appeared to be not very confident in their ability to detect and manage cognitive impairment, with a score of 19 out of 30. But they did demonstrate that they have a high regard and felt it important to detect and manage said care, as evident by the attitude towards care score of 26 out of 30. However, when assessing their engagement in detecting and managing cognitive impairment, there was a fair to low score of only 9 out of 15, demonstrating the fear and frustration that I'd probably alluded to earlier. And I say all of this with a grain of salt. You may have already noticed that none of these 3 constructs changed much after the DAC study, as we can see from these very well-aligned blue and yellow pairs of bars. And while this is interesting, it is not so surprising, and here's why. It was not the actual doctors who administered the digital cognitive assessment test to patients in the study, but rather the study's research officers. Doctors' role in the end was more to give consent to recruit participants or patients and be supportive of the process. So we would not expect a big change of scores in these constructs per se. And in fact, if the research officers were to have done this survey, we anticipate that these constructs would probably all increase after participating in the study. And this is going to come up later on in Beth's presentation coming up next. And I can say the same if the doctors are actually the ones administering the digital cognitive assessments as well, that these scores at endpoint might likely be higher. So to summarize, survey results indicate that doctors have positive attitudes towards dementia care, but perhaps education-based training, focused more on improving confidence in their clinical ability and hence engagement with patients may improve early detection and care of patients with cognitive impairment, particularly as new diagnostic and therapeutic options may emerge. Now let's talk about the reported study impact based on the qualitative data or our interviews with these doctors. So Dr. Jenny reported 3 positive outcomes. First is increased knowledge and awareness. Doctors express their appreciation in knowing more about cognitive impairment overall, about different diagnostic proteins that they've not known of before. There's sometimes shocking appreciation of what they once would have considered a normal lapse in cognition in a patient, as now something potentially serious and worth investigation. And learning that cognitive impairment can start much, much earlier than what is obviously apparent from direct contact with the patient. They appreciate the importance of not taking for granted that a patient is totally cognitively intact. Also, doctors who used the screener reported that it changed their care management. They noted being more comprehensive and aggressive in their care. For instance, instituting investigations from the get-go instead of waiting and watching. And being more willing to take the time to do a routine screen, which we all know now is quite a barrier to overcome. But especially for patients with comorbidities or other illnesses like cardiovascular disease, depression, or those with poor diet or sleeping issues, where cognition could be impacted as well. Also, I should note that doctors mentioned that patients were generally receptive to the screening feedback reports, which is also very helpful for positive reinforcement for the doctors to continue their screening efforts. And lastly, empowerment. So this new knowledge and experience in screening for cognitive impairment made doctors feel like they can actually make a difference. Intervening earlier means that they can prolong quality of life, and so patients do not end up as an unfortunate, too late to make a difference case as they do now. And now, what you might be thinking at this point is that what I'm telling you now is a bit opposed to the survey results in the bar charts I just shared, which indicated that none of these kinds of changes occurred. Well, we need to keep in mind that the survey only looked at the use of the digital cognitive assessment, which the doctors did not use. The qualitative interviews, on the other hand, reflected not just the use of the digital cognitive assessment, but participation in the DAC study more broadly, including engagement in research activities, engagement with the Brain Health Navigator team, engagement with patients and other practices. So encompassing the wider scope, participation in the project provided doctors with positive outcomes overall for dementia care. And this is where mixed methods research, that is quantitative survey data and qualitative interview data here, is so important. The qualitative interview data is able to pull out nuances from the more two-dimensional quantitative or survey data results. Okay, takeaways. So we've talked about the DAC study, doctors' care management process, their reported challenges, their suggestions for improving these challenges, and the impact of the study on them. So what is this all saying to us? First, that the current care pathway for persons with ADRD is not adequate. No, doctors currently do not conduct routine cognitive screening. And yes, they struggle to work with patients with potential cognitive impairment due to time and resource constraints and lack of training, for example. Nevertheless, however, doctors are hopeful and optimistic to implementing an improved care management pathway for ADRDs with resource support. And though initiatives are welcome, doctors felt that the prospects of implementation are likely to take years and will require private-public partnerships. So that is all from me. I'm going to hand the mic over to you now for any questions and comments. Thank you very much.
Thank you so much, Catherine. Those were such integral insights from our participating doctors. As we can see from the engagement in the chat, our doctors continue to be active and engaged and really wanting to figure out how can we provide the best care possible for our patients. We see a lot of interaction between primary care and specialist care. And we know that in the Jamaican context, and likely in many other Caribbean contexts, there is this relationship between primary care and specialist care, particularly when it comes to cognition-related concerns. We know that there is a lot of interaction between our GPs and psychiatrists. We know that in some of the practices in this DAC study, for example, there was a psychiatrist that was part of the team. And so we believe that these types of cross conversations continue to be important, and we look forward to hearing more from you, our participants in tonight's webinar, about all of these insights that you're having. Thanks so much for continuing to share them and keep staying engaged in this chat. We're now going to switch to understand a bit more about what our research team officers had to share about their insights. These were members of the team that were deeply embedded in both physical practices, medical practices, and in the communities when we did events. And so it's really important for us to understand what insights they had during the fieldwork process and even during the buy-in process when we had our continued conversations with the practices to understand their workflow. So now we're going to hand over to Beth so that she can share more with us about our research officer insights.
Good day. My name is Beth Gallimore, and I'm a Senior Research Officer at Amaji Health Limited. In this presentation, I will be discussing the research officer's perspective of the barriers and facilitators of implementing digital cognitive assessments and tests for reversible causes of cognitive impairment for Alzheimer's disease and related disorders, also known as ADRD. The research officers maintain notes throughout the study to document their findings and reflect on their experiences. So firstly, a little background about myself. I am a mental health researcher and consultant. I am very passionate about global health, with particular interests in developmental cognitive neuroscience, mental health stigma and discrimination, and parent and child attachment. My passion for health and well-being across the lifespan has only been strengthened by becoming a mother myself to my amazing son in April 2023. I have worked under Dr. Ishtagavaya previously as a research officer on the Savvy Caregiver Program Jamaica, where I was involved in the adaptation of data collection measures and conducting interviews for caregivers of persons who live with ADRD. I'm also in the final stages of completing my PhD at King's College London in the UK, in the Health Service and Population Research Department within the Institute of Psychiatry, Psychology and Neuroscience. My PhD project is titled Mental Health Among Young People in Barbados, Stigma and Help Seeking. I also have a deep love for the arts and have played the piano for near to 20 years. I obtained a first-class undergraduate Bachelor in Music degree in music performance at the University of Chichester Conservatoire in the UK, specialising in classical piano. In today's talk, I will first address the barriers identified, followed by the facilitators, before moving on to recommendations made by the research officers to assist in implementing digital cognitive screening, and closing with the takeaways of this presentation. The themes for each of the categories were identified through a rapid framework analysis approach, for which we used pre-established areas of interest, specifically barriers, facilitators, and recommendations, to summarize the data. We used a team-based qualitative rapid analysis, where two senior research officers, namely Janelle Robinson and I, met regularly to identify and report patterns in the data, which resulted in a set of themes and sub-themes. Today, I will focus on the key themes before we move to our discussion. Throughout the presentation, I will refer to patients, who in this case are the individuals who completed the digital cognitive assessments and/or tests for reversible causes of cognitive impairment. When quotations are presented, these will be from the research officers. Here is an overview of the characteristics of the research team. The field research team was all women, aged between 23 to 44, with over half under the age of 30. The young age of the majority of the research officers is indicative of the task-shifting approach that was used in the project, where the implementation did not rely on personnel with extensive graduate and advanced level training. Instead, the project leveraged the availability of recent graduates from undergraduate studies and/or graduate studies with a desire for short-term and part-time employment and for applied research experience. This pool of research officers was enthusiastic to learn on the job, to get research experience in a supportive team environment, and to contribute to a good cause in the country. They were willing to work not just with the doctors, but also with the patients compassionately and with empathy, and to act as an intermediary between the two. The vast majority had a background in health and allied fields, such as medicine, psychology, public health, and pharmacology. Only 2 team members had backgrounds in other fields, one with a graduate degree in politics and the other a bachelor's in business administration. Having a team that largely had a strong medical or allied health background fostered great trust from the patients to the research team. What was also highly influential was that several team members had strong ties within the communities, such as places of worship, and all individuals had a strong background working with people, and so generally good interpersonal skills, which helped them to be comfortable with and a comforting presence for the patients. Now on to exploring the barriers to implementing digital cognitive screenings. Firstly, misunderstandings of ADRD and brain health. Second, time constraints. Third, lack of infrastructure, both digital and physical. And fourth, cumbersome local care pathway. During implementation, the research officers identified that there were many misunderstandings or misconceptions around ADRD and brain health in general. This was particularly noted in two areas. The first being a lack of need to participate. Some patients believed that they did not need to participate in the test as they did not consider themselves to be experiencing any cognitive impairment, such as confusion, memory loss, and difficulty concentrating. Patients did not understand that the project was intending to implement timely detection of ADRD. They were not aware that in some cases of changes in brain functioning, the changes might be subtle and not glaring, and that digital tests, like the one used in the project, could pick up these subtle types of changes. Therefore, the absence of apparent symptoms deterred their willingness to participate. The second area of this theme was stigma towards mental health. A number of patients were hesitant to take part as they associated brain health with mental health. The continuing stigma surrounding mental health led to some individuals continuing to see this as being mad, which acted as a barrier to taking part. Subsequently, a critical consequence of there being a lack of ADRD and brain health awareness is that patients are often diagnosed when they are at a moderate stage of cognitive decline, rather than at an earlier stage, which was spoken about in more detail during Catherine's presentation. Moving on to the second barrier, a key theme that emerged from the data was time constraints. The research officers noted that time was a prominent barrier in all aspects of the implementation process. One of the main areas was in relation to competing health priorities. The research officers found that in recruiting and saying that the actual test will be 10 minutes, this sometimes acted as a pull. But most people came for one purpose, to see their doctor for their intended purpose and wished to achieve that and that only. There were concerns that by taking part in the study, they would lose their place in the queue and lose their doctor's visit if they were engaged in the cognitive assessment. There was a lack of understanding that the research team had already had conversations with the doctors. The doctors would be given the cognitive assessment report, which would then be discussed with the patient in their appointment, alongside discussing their original health concerns. Future implications of this finding mean that it would be important for an organisation, such as Amaji, who have brain health navigators, to come into the practices and conduct, for example, a clinic day, for patients to be able to have cognitive assessments administered. Alternatively, doctors could be trained to administer the cognitive tests and report the results so that this could be done within the practice during a separate appointment, which is another service that Amaji offers. The research officers also noted that in implementing the study, the lengthy test administration was a deterrent to some patients from taking part, and for others, it made them easily fatigued. There were two key aspects to the test administration process, and that was the consenting process and then the cognitive assessments. Before patients could begin the assessments, they had to provide consent, which involved a lot of information that needed to be read to the patients, as well as several forms to sign. This caused some people to lose interest and feel less inclined to participate. The research officers noted this and began introducing batch consenting, where multiple patients simultaneously completed the consenting process. This was successful in helping to speed up the process so that patients could move on to complete their assessments in a more prompt fashion. For patients who began the assessments after completing the consenting process, they became easily exhausted after all 3 assessments that were a part of the screening. Subsequently, the last part of the assessment process, the patient's self-report, tended to be omitted. As this was all part of the study, in normal circumstances, a consent process would not need to take place, which would shorten the time of the overall process. The implementation of timely detection in Jamaica also faced the common barrier of lack of infrastructure. Firstly, physical infrastructure. Some of the key challenges raised by the research officers were not having enough space to conduct the digital cognitive assessment, or the rooms being too small to accommodate the patient as well as relatives whilst implementing the tests. For some patients, having the presence of family members provided reassuring support. For others, family members were keen to be in the room to observe what was taking place. Also raised was a lack of privacy due to thin walls, the distance from the room to where other patients were, or when there was the presence of other relatives, as well as the presence of the research officers themselves. And this was important as part of the assessment involved a life and health questionnaire, which made some patients emotional as they were required to reflect on their emotional state, previous life events, and traumas. And lastly, where the tests were conducted at health fairs, there were frequent comments about noise interruptions. And this was particularly important in this study, as using the Linus tool, part of the assessment involved patients hearing a word and then repeating it back to the device. This was challenging for some patients who could not always hear clearly over the noise, and this challenge was further exacerbated by the voice from the Linus tool having an American accent. Additionally, the background noise would sometimes be picked up by the tool, which caused scoring errors. Digital infrastructure also presented as a barrier. Because our digital cognitive assessment is tech-enabled, it required the use of Wi-Fi, and in some cases, there was no access to the internet or the connection was unstable. We had the use of the Linus tool as well as a Samsung tablet, which is what the research officers used to collect some of the data from the patients. When there were connection issues with one tool, occasionally the team would be able to share the data from the other using its hotspot function. However, due to the remote area of some locations or the poor Wi-Fi in other urban areas, this was not always possible. The team did have a number of external hubs which allowed for Wi-Fi connection. However, this was not available at all sites. This highlighted the need to acquire screening tools that are not dependent on Wi-Fi to be able to carry out the intended tests. The research officers also noted that they had to rely on healthcare practices for printing. This was particularly challenging as the Linus reports were several pages long. The practices were compensated with paper and ink to help facilitate the printing. However, there was still the challenge of needing to coordinate where the printing results would fit into the printing queue, when in a small practice, there were many documents being printed at one time. It was paramount to ensure documents did not get mixed up with other patients' information to preserve patient confidentiality. During the fieldwork period, Ishta, the project coordinator, and the research officers had online weekly meetings, which were also recorded for those who could not attend. These meetings were to help ensure that everyone on the team was following the same protocol, and any challenges could be raised, such as the challenges encountered with infrastructure, as well as general debriefing from the previous week's experiences, such as how the data collection was going, lessons learned, what went well, and what other challenges were encountered, to help improve the efficiency of the process. Through sharing many of these physical and digital infrastructure limitations identified in the weekly team meetings, the team realised that it was necessary to conduct site visits prior to conducting any screening when possible, to try and provide solutions to some of these logistical challenges when possible. The last barrier I will speak of today is a perceived cumbersome local care pathway. What this means is due to the lack of clear next steps and lengthy wait times between tests for answers in Jamaica where there are cognitive concerns, research officers observed that individuals are discouraged from participating in the study and by extension routine screening due to the uncertainty and inaccessibility of care. Generally, patients themselves are unsure of what steps they should take, and equally, they can sometimes sense that their doctors do not know where to send them. Patients are unsure how to access the necessary investigations into any cognitive impairments they may be experiencing. If this was not their primary health concern when attending their doctor's appointment, they are unlikely to follow up. If patients do get to the stage where they are referred for specialist care, practitioners have confirmed that there currently exists a very lengthy referral process, as detailed further in Catherine's presentation. Now moving on to some of the facilitators that were identified by the research officers. The 4 themes I will be speaking on today are 1. Person-centered interactions, 2. Research officers' training and skills, 3. Financial subsidization, and 4. Engagement of medical doctors. A notable facilitator for implementing digital cognitive screenings of ADRD in Jamaica is taking a person-centered approach to interactions. The research officers tailored communications and instructions around patients' needs. For example, communications were tailored through the adaptation and clarification of American language. The screening tools were not developed for the Jamaican population, and subsequently, there were occasional misunderstandings during the test due to accent and language challenges. For example, within the Linus assessment, there was a section where patients were instructed to recall a list of words. The word daughter was not able to be clearly understood by the AI voice, as it was not pronounced as it would be when spoken with a Jamaican accent. This was a notable distraction for patients and did hinder their performance. To assist with this, when patients struggled to understand the instructions delivered by the Linus tool, the research officers clarified terminology with the use of Jamaican vernacular, which helped in patient understanding. The Linus tool also allowed the research officers to repeat or restart a section when necessary. Patients also had various educational backgrounds. The research officers identified that those with lower educational levels tended to take longer on the digital cognitive assessment and needed a little more support with understanding some of the questions. In contrast, those with higher levels of education understood the process with greater ease. The research officers therefore found that it was best to use an approach where instructions were explained using very simple language without use of jargon, and instead, when appropriate, utilizing patois and analogies. Although the digital cognitive assessment was not a pass or fail type of assessment, there was a degree of performance anxiety among some patients. Sometimes this was partly due to some patients being unfamiliar with how to use a smart device using a digital pen. To try to minimize this effect, the team provided sensitization training prior to patients taking the screening assessment to support them in using the tools that were required as part of their orientation to the study. It was also important for the research officers to remind some patients that they could not fail this assessment, as some were worried about answering incorrectly. What also helped to ease patient concerns was to inform them of the benefits of completing the assessment, communicating that the information they received as an outcome of taking part in this screening process would be able to provide them with practical next steps to help support them with managing and taking care of their brain health. Lastly, communicating with patience and empathy was crucial. When patients seemed distressed, the research officers were able to provide the emotional support that some of the patients needed by empathizing with the individual about how daunting and emotional it can be to take this type of test, but that they are here to support them. The next theme that facilitated implementation is research officers' training and skills. All the research officers were Jamaican, and many were Jamaican healthcare professionals, which was a key contributor to increasing trust among the patients. All officers were professionals in their respective fields, including those who were not in healthcare, and their strong communication skills helped them build a connection with patients. The research officers came into the study without any formal extensive training in ADRD. They each participated in an onboarding process and received on-the-job upskilling. At the beginning of their time with the team, each would shadow each other and other team members during fieldwork for recruitment and data collection. Throughout fieldwork, they attended weekly debriefing meetings to review what went well and what were lessons learned from the previous week's fieldwork. Synchronously or asynchronously, through listening to meeting recordings, they also participated in review and training sessions with the Linus Health team and were invited to the meetings of the Dementia Diagnosis Advisory Group. These opportunities offered education about Alzheimer's disease and related dementias, as well as in-depth training and familiarization with protocols. The research officers also were active in shaping iteratively the project implementation by providing inputs that helped to tweak the processes and procedures. These factors were connected to the research officer's increased confidence and capabilities. Moving on to financial subsidization. The free-of-cost nature of the cognitive screening made it possible for patients who otherwise would not have access to these services have access to them. During the recruitment phase, even if it was mentioned that the service being offered is free, a potential participant would counter that they don't have the money to engage in the process, at which point it would then have to be repeated that the service is free, and again when the blood tests were being discussed. It also helped to inform patients that they would not need to travel to another location to be able to take part and have the screening test done. Everything would take place at the venue, in this case, either the doctor's office or health fair, that they would have been at irregardless. And for those in attendance at a health fair, the majority tended to be more interested in their health and were not usually in a rush to be elsewhere. To conclude the facilitator section, in order for us to be truly successful in the feasibility of implementing routine cognitive screening, research officers noted the high importance of engagement of medical doctors, in this case, those who own the practices or whose practices in which a recruitment occurred. Medical doctors who were engaged in the project were key facilitators in supporting patient willingness and comfortability to take part. They helped put individuals who were unwilling or skeptical at ease without any coercion. Additionally, the medical doctors were able to function as a bridge to relay necessary information to patients that convey the importance of the tests, as well as the benefit for their own patient care. Whilst the doctors themselves did not feel like they had the time or capacity to administer the cognitive screening, they saw the value in these tests. Those with the most buy-in with the study were particularly keen to encourage their patients to get the screening done and emphasize how the screening would be useful to assist in their overall care management. Having a partnership with the medical doctors, this being a collaborative process, was crucial to the successful implementation of the screening. Here I'll be focusing on some of the recommendations made by the research officers that would support the implementation process of routine cognitive screening. One of the key suggestions from research officers surrounded efficient operations and workflow, describing how research officers can employ strategies to optimize time and resources, making the process smooth and professional from beginning to end. For example, from ensuring to call to confirm appointments the day before the appointment is scheduled, to capturing email addresses or WhatsApp numbers to conduct follow-up, an essential part of maintaining continuity of care throughout the process. Research officers also recommended that brain health navigators that will be offered by Amaji are needed to fulfill the service gap. Currently, healthcare practitioners, or HCPs, have in general taken a hands-off approach, and there exist several legitimate and understandable reasons why they may have chosen or been forced to do so, including but not limited to lack of confidence regarding dementia screening, care and management, time constraints to conduct regular cognitive screening, and an unclear pathway to diagnosis and treatment, as was spoken about in Catherine's presentation. This all signals a need and a space for a brain health navigator service. Lastly, one of the most important recommendations is the essential need for HCP buy-in and involvement. The active participation of HCPs is crucial as it greatly increases the likelihood of having more patients receive routine cognitive screening and thereby increase the chances of timely detection for ADRD. Patients are more likely to participate if the subject is broached with them beforehand by their healthcare practitioner, and if their healthcare practitioner encourages them to do so. Additionally, likelihood increases if their HCP is the one to coordinate the setup of the appointment for the digital cognitive assessment and administers the assessment to them, which is a service that Amaji also offers, training HCPs to deliver routine cognitive screening. To conclude, 3 key components are essential for the successful implementation of routine screening. First, knowledge of ADRD, and the importance of timely detection. During the study, we prioritized building relationships with key community organizations, not just medical practices, but also, for example, places of worship, community leaders, and volunteer organizations, to raise awareness about the importance of brain health and healthy aging, including the management of chronic conditions as people age. This helped to build trust with local organizations by understanding each community's needs for healthy aging in each community's context. Having a research team with several officers with ties to the community also facilitated this. This approach helped to meet patients where they already were. While most of the research officers had a background in medicine or healthcare, all were enthusiastic individuals with a strong willingness to learn and were flexible, which was a key contributor to their acquisition of ADRD knowledge. The second key component, confidence in applying screening to a wide variety of patients, such as those from different demographic backgrounds and differing levels of exposure to the medical system, for example, and interpreting results to be able to communicate these to patients in an understandable way. And lastly, the time and resources to support patients through this process. Many primary care providers found it challenging to incorporate the new workflow for timely detection due to time constraints and lack of confidence. The research officers were able to be flexible in supporting the implementation of the screening in the primary care workflow and provide resources to patients to help them with their brain health management. This support was crucial in making the patients feel cared for and supported. Overall, the research officers were essential to the successful implementation of screening in this study. However, a key ingredient for this success was the buy-in from HCPs. The team in upcoming presentations will provide practical solutions as to how to bridge the current barriers. Thank you so much for listening, and we would like to open the floor for any questions or comments.
Thank you so much for those insights, Beth. In our experience, our research officers were essential in getting this project done and in getting this project done successfully. So we have major thanks that we send out to our research officers, some of whom are on today's webinar. We're really happy to be able to share with you and also to speak with you. So at this point in time, we're going to shift into a discussion. We have our speakers from today, with the exception of Dr. Selza, who had to leave for a prior engagement. And we'd also like to invite you, our attendees at this webinar, to participate. Please share your questions. Please share your insights. We want this to really be an engaging and engaged discussion. So please let us know if you'd like to raise your hand, if you have something in particular that you'd like to contribute. And we're going to start off by just starting with some of the concerns that many of you raised in the chat. What is the role, for example, in a context like Jamaica, where there is such limited access to even essential medicines, for a pathway to lead to a disease-modifying therapeutic? Many of you have raised this type of concern in the chat, and some of you have raised it offline to me in other questions. This is a real issue for us as we think about, what does healthcare system preparedness mean? Does it mean instead a shift to focusing on chronic non-communicable diseases and the risk factors for chronic non-communicable diseases? Some of you may be aware of the recently released update of the Lancet Commission on risk factors for dementia and the prevention of dementia, and the updates to that list of factors, which include and reiterate the role of a life course approach to risk factor reduction. In early life, education is really important, and we know that a large number of persons in contexts, like in many low and middle income countries, do not have access even to primary education. We know that we have high levels of illiteracy and low levels of numeracy as well. And so addressing risk factors is crucial, as some of you have noted in the chat. Addressing hearing impairment, addressing vision impairment, addressing high levels of cholesterol, diabetes, and uncontrolled hypertension as well. These are areas where we believe it is really important to focus our attention in contexts like ours. But we'd love to hear more from you in terms of your questions and any insights that you have. I'm going to pass this over to our panelists to ask for any insights or questions you might have in terms of the cross-conversation gleanings from our sessions today so far. Is there anyone who'd love to start?
Sure, I'll go ahead. So one of the things that's also coming out in the chat more broadly is how do we tailor this type of intervention, this type of timely detection within a low to middle income country such as Jamaica, where resources are limited. And as Beth pointed out, the time constraints within the healthcare sector as well, and as Catherine pointed out, are limited. So just would like to hear from others as well. Within the chat, we see some doctors who we're quite familiar with and have relationships with that may have some insight in terms of how do you think within your practices or amongst your colleague, we can further tailor this approach that we can better meet the needs of the individuals within Jamaica, and not just within the urban setting, but also within rural Jamaica.
And we have Dr. Anna Brown Morgan, who is wanting to contribute to the discussion. So if we can have her speak.
Okay, so here I am. And I've been listening. It's been a wonderful presentation so far. A lot has been gleaned, but it's just that I think that going in, if the screening of practices were tailored to some of the issues, so that next time around, you know, some of the issues that came up, for example, privacy. Where are these ladies and gentlemen going to speak their hearts honestly, without the fear that, you know, it's going to go around town, and who they speak to? So there's more than one set of information you want to get. One, you want to get the truth, what's happening in Jamaica with regards to dementia, which requires maybe smaller numbers, or maybe to get the numbers a longer time for the program to run, but to get completed the various phases completed, and to have the knowledge that there is continuity of care with the same physician. So that's one thing. The other thing, of course, would be what pertained today, which is you get feedback, generally speaking, from various types of health services, where you get what actually pertains, which would pertain the problems that would pertain to getting this information called Jamaica the Globe, well, globally. So if you getting the knowledge, the true knowledge, would depend on getting the proper testing done and getting and you need to tailor for that side of things, which is possible, but it's just that you have to you have to visit your site. So, and then the other stuff now says the reason why there are difficulties, the reason why there are things not completed, the reason why things are not as finished as they could be. So I just wanted to point that out. Also, the use of the NHF, start pushing there, because, you know, we've spoken a lot about healthy lifestyles, exercise, sleeping all right, eating all right. And we've also spoken about the chronic diseases, which are many. We even haven't spoken about sickle cell, all these other things which will be causes of dementia. There's a lot of stuff that the NHF has actually put on board now as chronic, which all of them can cause dementia. And therefore, to get your medications on board, we know we have to lessen those, all of that, before the dementia medicines are acceptable. So you need to put a program, though, for dementia, for inception of early treatment, so that we have a community, a society that can function for longer, So I guess that's what I wanted to say.
Thanks so much, Dr. Arna Brown. In terms of you've definitely identified something about the design of the project. This was an implementation science study. So it was not a clinical trial. It was not a cohort study. It was an implementation science study where we were looking at barriers and facilitators. And so you're absolutely right in terms of whether or not we want to get quality, detailed information on a smaller cohort, or conduct a clinical trial, for example, on a lifestyle intervention, or figure out the effectiveness of a particular care pathway that we want to trial. Those are separate types of studies. So what we are attending to in an implementation study such as this one is to understand the barriers and facilitators. So understanding, not addressing, but understanding, we can some of these barriers, such as what you've identified, privacy, which Beth spoke about from the research officer's reports, was really important for us, that we note what these barriers are, that we note what the facilitators are. And to the extent that we are able to manage that particular factor in a specific context of data collection, we do our best. But it was really important for us to observe and to record these barriers and facilitators. Then in terms of the NHF, the National Health Fund, for those who are on the webinar who are not from Jamaica, this is our health insurance, national health insurance in Jamaica. And you're absolutely right. We have been lobbying, as you well know, because we have a strong partnership with the Caribbean College of Family Physicians over the years. And we have been lobbying, and we have been working in the background as well with the Ministry of Health and Wellness to advocate not just for more thorough provision of and access to essential medicines, but certainly for adding on some of these diagnostic procedures. A lot of them are actually covered in terms of the test for reversible causes. We know we are still a ways away from getting coverage for medication that addresses the symptomatic approaches to dementia care. So donazepam and Namenda and all of these other medications. So we are even further than that in terms of if and when a disease-modifying therapeutic becomes available, the long duration that it will take to actually likely get that on the VEN list, the list of medications that are going to be made available in our country. We know from other research as well, conducted by the DAC program and researchers within the DAC program, that in many contexts in high-income countries, excuse me, in many contexts in high-income countries, even if a disease-modifying therapeutic was available right now, there would be a long waiting time, and by long, sometimes this waiting time is between 2 years to over 10 years of people who are actually eligible for that disease-modifying therapeutic to actually get that disease-modifying therapeutic. And by eligible, we mean that they actually have the specific pathology that that therapeutic is meant to address. So if that therapeutic is meant to address amyloid-related abnormalities, then they would have needed to have screened positive for those. And in order to screen positive, we need all of these other things that we have been talking about today in terms of the screening procedures to actually be in place. So yes, you're absolutely right. The standard of care guidelines we'd started to work on this in the process of undertaking the STAC project, and we're keen to continue working on it. And as we've been advised by some of you, our colleagues in the medical community, for this to actually stick, for it to be developed, it needs the ownership of the Ministry of Health and Wellness. And for that to actually happen, we need it to be really built by our medical community. And so we are keen to continue working on these standard of care guidelines with any of you who are interested in really taking ownership of this as well. Other questions, comments, anything from our panelists so far?
Ishtar, I just want to acknowledge in the question and answer section, Dr. Bandara Kaur, definitely. So one of the things that we've highlighted in the gap is how do we support our healthcare professionals? We spoke about the barriers, and you mentioned here to really train the brain health navigators. We do have a pool of brain health navigators that are currently trained, and our aim is to really increase that pool to be better able to meet the demand that is out there. You also mentioned training the doctors. That's also something that's in the work, and this is actually not the first webinar that we've done, but we do intend to have other webinars looking to really upskill. And I know towards the end we're going to be speaking more specifically in terms of the nature of those upcoming workshops, because we really want it to be interactive. We really want it to be a situation where in the end we can, as doctors, GPs, you can look at a report, you can glean or you can interpret what's on the report and come up with culturally relevant recommendations for your patients. So these are things that are actually in the works. I'm so happy to hear that we're all on the same page. And okay, someone else in the chat. Oh, definitely. Yeah, definitely. Again, from Dr. Bandara Kaur, taking that holistic approach, and really, that's why earlier Ishta and Aria, Dr. Robert, in her presentation was talking about the difference between timely detection and early detection. And within my presentation, talking about the difference between reversible causes and treatable causes. So definitely there needs to be a distinction between treatment and recovery, or as you put it here, healing, and having that good balance and really pushing and promoting this idea that interventions such as lifestyle changes, such as diet and exercise, can truly go a long way as well. And I think Dr. Prescott is saying the same thing, just the intersectionality of the biological, environmental, and situational factors. And protective factors do shadow the risk factors as well. Ishtar, you wanted to jump in?
Yeah, I just want to say that we are totally on the same page about this, because before we move in any direction of disease-modifying therapeutics, we really need to address our risk factor management. Our risk factor identification and risk factor management. A number of you have said, even in the chat, that there is such a high prevalence of non-communicable diseases and risk factors for non-communicable diseases in our populations. We know this. And these risk factors and this high prevalence of these risk factors and the high prevalence of the non-communicable diseases is actually one of the reasons why one of the adjustments that we made for the Jamaica site, one of the adaptations, was we lowered the age, because we knew that if we were starting at 65, it would really make us be getting persons who were more advanced in terms of the progression. So it was important for us to start with a lower age threshold for entry into the study. But we are totally on the same page in terms of wanting to ensure that any type of tech-enabled, data-driven solution for our context are really revolving around risk factors and really identifying those. Because as our colleague, Dr. Roberts, who is a close collaborator of ours, as he's noted, it's crucial to address these risk factors before and in tandem with even trying to identify reversible causes of cognitive impairment. So we'd love to hear from any of the other voices online, even our research officers who are online. If there are any persons who are open to sharing and chatting more, please feel free, and any other questions that we need to address. We see online counseling has their hand raised. So can we enable online counseling to have speaking privileges? I see that my image is frozen on the screen. I'm not sure if you all are hearing me. Okay, super. All right. Is online counseling able to speak?
So if I can jump in while I guess online counseling is working their mic issue out. I just want to jump in also and add that, what's interesting, what's so important here as we talk about the holistic care and the importance of risk factors and protective factors is, a lot of times what came up in the data was that, we need to work with our governments and get the national plan to be, more recognizing that dementia is something we need to deal with. And when we're looking at risk factors and how much these risk factors are shared between, yes, dementia, something that people don't want to focus on too much because, the stigma and the ageism, working on the risk factors and lifestyle factors that can help with things like ADRDs is also going to affect obesity, is going to affect hypertension, is going to affect diabetes, which are all very significant conditions in the Caribbean. So I think one of the biggest things that's a takeaway here is, as we're focusing on, policymakers, is that, this is a 2 birds, 1 stone sort of situation, or 10 birds, 1 stone situation, because we look at risk factors and protective factors that are shared between all these different conditions that are afflicting our countries. We're doing a lot more than we think. And if we highlight that mental health is always also being affected by these risk factors, perhaps there can be a lot more initiative to focus on them.
Thanks for that, Catherine. Really crucial. And as we've noted in the question and answer, we're hearing from some of the attendees about these intersections as well. I want to point out a couple things related to ethical concerns. A number of the participants were from a lower educational background. And so this raises issues in terms of as we've pointed out throughout the many presentations today, the consenting process and really providing patients and participants in a particular project with adequate information so that they can make an informed choice about participation. And so the research team spent a lot of time, and this is why the consenting process sometimes took upwards of 2 hours at the very beginning, to really help participants understand what each of these consent forms, because there were 3 different consent forms that the ethics committee required that we have in place, what each of these meant. And so it's something to think about in terms of ethical considerations about informing participants, as well as understanding burden on participants and what it takes to actually get someone to understand what it means to participate in a particular project. There are also other ethical considerations and questions that have come up in this project. The blood-based biomarker test, which Jamaica did not implement, is one that detects, as Ariel pointed out in her presentation, amyloid-related pathologies. And because of that, a positive screening for amyloid-related pathologies, persons would then be channeled into understanding that they would be likely they would have a higher likelihood of being diagnosed with Alzheimer's disease specifically. In a context like many countries in the Caribbean, with the exception of, I believe it is Bermuda right now, where there is a cutting edge startup called Carry Genetics, genetic testing is not widely available in the Caribbean. And so the type of testing and the follow through for some of these diagnostics and what they're meant to lead to is really something for us to think about critically in the Caribbean region. To what extent are these diagnostics really reflective of the needs of our conditions and our context in the Caribbean? And this is where, again, this conversation about the risk factors is really crucial. We're getting a question from Dr. Brown Morgan about could blood samples not be sent overseas at cost of researchers? I'm not sure if you mean the blood-based biomarkers. But we could not get export permissions arranged in time for that because it was the sequential administration that was important. Persons needed to have been identified from the digital cognitive assessments as either borderline or cognitively impaired. Then from that subset, those needed to have gone on to complete tests for reversible causes. And then from the subset of those who did not have reversible causes identified for their cognitive impairment, that smaller subset of persons would have been the ones who were eligible for the blood-based biomarker. Because of the length of time that it took for that sequential administration of the digital cognitive assessments to the test for reversible causes of dementia, the export license could not be arranged in time. The online counseling has raised their hand. Don't see any mic control, but what are we going to do about organophosphate use on food and for insecticide that is a serious neurodisruptor and used in hundreds and thousands of gallons in Jamaica? Yes, we have been seeing increasing research about the impact of toxins on brain health. And we know that this is really especially important for our farmers, and it's really especially important as well for those who are even exposed in their homes to toxins like mold. And we know that there are some environments in the Caribbean where mold is really high because of the levels of moisture and humidity. So these are important questions that we are raising in terms of which factors ought we to be addressing. Any thoughts from the panel or from anybody in the audience about the ethical types of issues that we have been seeing emerging from our work so far? Sure, Dr. Levy. It would be lovely to see you on and hear. It would be great to hear you too.
Thanks, Dr. Govia. Good evening. And to you and to the rest of your team and to everyone else participating in this webinar. We have been looking forward to this presentation quite a while, and we're happy to have heard it thus far and heard the progress you have made. Out in the field though, what do you recommend based on the information you have gleaned so far from the study in terms of us developing a strategy for early intervention? What is it you recommend? What are the steps you think we should be taking even now based on your findings thus far to detect as many of those of our patients with early signs of Alzheimer's disease and its related disorders, so that we can at least begin to put in some methods or some programs to reduce the development or reduce the pace of development. Any thoughts on that?
Yes, thank you so much for that important question, Dr. Levy. Yes, in terms of recommendations, specific recommendations, we certainly need to advocate for widespread availability of these tests for reversible causes of impairment and full subsidization if at all possible. We saw, particularly in some practices, where even when the doctors referred the patients to actually conduct these tests for reversible causes, potentially in prior appointments before they had done the digital cognitive assessments, the patients did not do the test for reversible causes because they did not have the funds to do them. And the funds to do them means the cost of the actual investigations. In the case of the panel, for example, that was used for the blood test that biomedical labs did for us, each of those panels costed over upwards of 180 US dollars. And the ECG had an additional cost attached to that. So a regular Jamaican is not able to afford those things. So one specific recommendation is that we do need to get these tests for reversible causes of impairment actually subsidized so that they could be implemented and used more widespreadly. Because it was, again, not just the test of the investigation, but these are people who sometimes have to save up to get that 4,000 Jamaican dollars to go to see the doctor in the first place. Because that would mean the doctor's fee, the taxi fee, and all of the other types of fees. If the doctor sends them to go to a pharmacy for some prescription, then they have to find the money for that as well. So really figuring out how we can enable the access to the tests, the investigations is important. Related to that too is very proactive and aggressive management of the risk factors. And the risk factors, as we've talked about in a lot of detail today. Another specific recommendation is workforce related. We do need to think through and to implement this type of task shifting model of care. We don't need to have, it would be great if Jamaica had hundreds of neurologists, but we don't have that. We don't even have sufficient psychiatrists, and we have some key psychiatrists from Jamaica on the call today. We don't even have sufficient psychiatrists to meet the needs of the population, especially in light of what Catherine was just talking about with mental health issues. So we really need to be creative, like how Jamaica really led the way in terms of thinking through an additional workforce cadre when in the early days of HIV, AIDS, and really figured out how can we have a workforce that is specifically dedicated to detection and management of cognitive impairment. And this is where Brain Health Navigators comes in. So I think those are three concrete recommendations. I would also recommend that we upskill the workforce. And this is, again, why through Amaji, we're offering additional workforce upskilling opportunities through asynchronous and synchronous types of offerings, virtual, as well as the opportunity to train on the spot in real life at your practices as well. I hope that those are helpful, Dr. Levy.
Yes, certainly, and I'm really very interested in the training that you will be offering to our staff and the various different medical facilities. Really interested in that.
Great. Yeah, and we hope to co-develop that with you, because as you let us know what the needs are, we can ensure that the training is really fit for purpose. So for example, we imagine that some of the practices, it would be you, the doctors yourselves, who are wanting to implement the cognitive screenings, or that you might want paper-based, as online counseling noted, paper-based tools instead of digital-based tools. And so we'd be happy to really work through with you and develop fit for purpose for your particular workforce cadre, a relevant type of training.
Thank you. Very interesting. Thank you so much. Excellent webinar thus far.
Thank you. Thank you so much, Dr. Levy. We also just want to mention that we are planning a sequence of dissemination sessions with the community partners and with the medical practices that participated in the project. And so, and with any other stakeholders, like some of you have mentioned NHF. So it would be really important for us to do a dissemination to the NHF. We are also hoping to speak at the Ministry of Health and Wellness's annual conference and to share some of these findings with them. So please let us know if you're interested in collaborating, if you're interested in working with us even to think through things like the standard of care guidelines as well. Other questions? So we have from Abigail on who was one of our research officers and was the team administrator, crucial role, and she's really held together a lot. Many of our participating medical doctors are very familiar with Abigail. She notes that one challenge the research officers faced during the consent process was that significant time was spent explaining what dementia is, as many individuals were unfamiliar with the condition and its symptoms beyond memory loss. Any thoughts from our panelists about that?
It's so throughout the several studies that we've had and throughout the years, what we know is that dementia is not a household term. So it's not surprising that a lot of time has been spent trying to delineate dementia and even further delineating dementia and the types of dementia. So for example, Alzheimer's, and explaining that dementia is that umbrella term. What needs to happen, and honestly, the only solution to this is just continued education. If we recall, like maybe some of the folks that were around during the 80s when there was a real push for the educating in relation to AIDS and HIV and reducing stigma and providing information. There was a real push for decades, and it was only until maybe in the 2000s where that stigma and just general knowledge became a household, just household knowledge. So we know that, okay, HIV, in terms of the communicability with HIV, X, Y, and Z, but those things took time. But the point is, we're going to have challenges and we're going to have individuals that are not familiar with the term. And the only way that we can really sensitize the public is for continued education. Within the practices, the word dementia and the types of dementia needs to become everyday language. It needs to be explained thoroughly to our patients so that we can really sensitize them. They can go within their families and explain the difference. And that's just a matter of taking time. One of the things that came up, I believe, in Catherine's presentation was that sometimes there was a hesitation from the healthcare professionals to really explain what dementia is, what's the risk factor, X, Y, and Z, out of fear that the patients may not understand and maybe put off from it. And we want to encourage healthcare professionals to kind of lessen that fear and to build the confidence in speaking about it in very simple terms so that our patients can understand, they can digest it, they can regurgitate it, and then share it with others. We've also done many, many public awareness campaigns. This is something that we have to continue doing. Your local radio stations, on the television, using brochures, putting those in healthcare centers, public and private centers, because it's going to take time. It's not going to be an overnight effort, and it's something that we have to just continue doing, and it has to be a collaborative effort. But I do take that as well, Abigail, as we know, but it's possible because we've done it with other types of diseases. It's very possible to really increase awareness and education, but it's going to take everyone to talk about it. Don't be afraid. Talk about it in simple terms until it just becomes everyday language for us all.
Yeah, thank you for that, Janelle. And it's very, very connected to what Dr. Arna Brown Morgan is asking about in terms of brochures to pre-sensitize patients. And in brochures, we also note the need, for example, to have things that are very visual that can really help. And as you probably have noticed, that's the approach that we took in today's webinar as well, because this is a webinar that's really meant to be broadly about sharing or disseminating the findings from the study, with the expectation that the audience would be broad. It would not be necessarily specialized. We did not expect that only medical doctors would be on this webinar today, but people who were our participants, people who don't have a medical background, people who are just interested in this topic. And so our approach with the presentations today, with a special shout out to Tiffany Palmer, who was really our graphics designer, as well as Marissa Stubbs, who did that beautiful animation, and Sean Mokian, who was the voiceover for us in terms of the key definition video at the very beginning. We realized from very early on in our work that it's crucial to have information available to persons in a way that is very understandable, very digestible, and does not require a ton of words on a screen. And so the media is critical here. And this is why one of the key approaches that we have taken as a team over the years has been to emphasize communication and communication strategies. And another key approach is to really think in terms of knowledge exchange, not as knowledge transfer, not of those who are in the hallowed walls of academia having information and other people being the receptors and the recipients of that information, but really understanding what is the information that the actual people on the ground have, and that there is great variability in terms of the people on the ground. So what do they want to share with us about what it is they need to be able to understand these concepts better? So Beth, please jump in.
Thank you, Ishta. Yes, I just wanted to just chime in as well to add what you said about the use of brochures. One of the facilitators that we found that wasn't spoken about in my presentation, but we did find, was that having used brochures in the study, that also facilitated people in taking part, because they were able to kind of take them, read through them, look through them with some relatives. And again, it's just those ways of accessible communication, which is a key thing that Amaji is aware of. And I also wanted to raise, since COVID, if we relate it to mental health, that has become much more of a conversation. And so equally, it's something, dementia is just going to need to be much more of a conversation, and it just continues to be seen as a taboo topic. And so even through things such as this dissemination today, it gets people thinking. Perhaps then, you can share with someone that you attended this today and talk about what it's about. It can get other people thinking. I think it's definitely, as you say, knowledge exchange. We all have a huge role to play with that, and it can be done in very simple ways, just by conversing with friends, colleagues, family members as such, so that people are more sensitized to dementia and know what could be a symptom, as such as many don't think it's apart from anything but memory loss, which is far from the case, but unfortunately is the widely accepted view. So I just wanted to add that in there.
Thanks so much, Beth. Yeah, I think it's really crucial, this talking about it, because one of the insights that we got from our interviews with the medical doctors who participated in the project was that they really did not have a clear understanding of what exactly this availability, for example, of disease-modifying therapeutics would look like. Some of them did not understand, for example, that these disease-modifying therapeutics are currently available in just infusion therapy form, not as pills. And so when you think about drugs like lecanemab and donanemab, which are all getting regulatory approval in the United States, for example, for use in research settings with the desire to roll them out in clinical settings, and the related infrastructure that's needed to be able to use to implement that type of treatment, it becomes really important that not just the regular layperson, but that the doctors as well understand the progression, the characteristics of Alzheimer's disease and related dementias, and what's on the market, what's available right now, and where does the market want to lead us in terms of understanding what's available, because we might decide those are not for us in our context. And it's important to really think about that as you think about some of these adverse effects from some of these disease-modifying therapeutics that are still in the early stages of development. Catherine, please jump in.
Yes, no, thanks, Isha. It's a great conversation going. And I think what's interesting here is also just including, we're talking about drugs and, you know, knowing the context in the Caribbean, we not be able to access drugs in other settings as easily. But even in other settings, in other, you know, in North America, we have doctors who also don't want to talk about dementia and are prescribing drugs just because they think they should. And what's happening is that they're not screening for dementia. They're writing off prescriptions and not focusing on the lifestyle factors, for instance. And what's happening as well in personal conversations, the pharmacists are then having to have these conversations with patients, which is not really their role, it's the doctor's role. So again, just this focus on getting the public and getting doctors up to speed with what is dementia. It's not just memory loss. What is available? How effective is it? Let's get screening and let's really just get on the path of really understanding this very big topic that we actually do have a lot of data on, but getting it out there to everyone in a good way that we can use it.
Yeah, thanks for that, Catherine. And you're right in terms of data, because data might be available, not necessarily how we think about it. Because what you've spoken to are, again, the risk factors. So we might not be able to identify all of the different types of dementia because we don't have dementia registries, for example. But we can move towards developing dementia registries. That can be one of the things that we co-develop and we work on as a community of practice who are really devoted and interested in this area and passionate about this area. But there are other data that we have. We have data. We have national level survey data in Jamaica, definitely in Barbados, in some other Caribbean contexts, about non-communicable diseases and risk factors. So we can start to actually tackle those types of issues, which are very specific to our context as well. The idea of differential diagnosis is really important. And this is where your question about and your suggestion about really working with the health and allied care community to continue to grow the understanding about these issues is really important. And this is something that, again, we're committed to doing. We have our colleague, Sandra Latiboder, who has her hand raised, and it would be great to hear her perspectives on this.
Right, unmute, okay. Thank you for this webinar, very informative. You're doing wonderful work, good to hear. What I wanted to raise, two things I wanted to raise. I'm glad your team mentioned about language as a barrier. It is important to highlight that because we know that we have, quite a number of persons who their educational levels are low. And so it is important for us as doctors, social workers, medical personnel to understand that when they're speaking to our clients, because sometimes the words that you use, it means different things to them. So it's an important thing that you have raised, and I'm glad your team highlighted that as one of the barriers. And it is something I think that we need to explore and we need to talk some more about. My question is, what is the flow when somebody is diagnosed with dementia? What should be the next step? Is it a specialist? What should we tell people after you have gotten a diagnosis, your family member has gotten a diagnosis? What are the next steps? Who should you go to in whatever order? That would be important for me to know. Thank you so much.
Thank you so much, Sandra. Just to reiterate, the issue about education and language is something that we are committed to addressing, and we even had ongoing conversation with the tech partner, which was in this case Linus Health, about the need to not just have British and American accents on the platform, but to really think about how do you develop fit for purpose again tools that would allow immediate recall and delayed word recall test to be said in a native language. So this is something that we continue to work on. In terms of the what do you do after a diagnosis of dementia, that would depend on the type of dementia. And we have specialists on the webinar as well who'd be able to speak more about that. But there are some medications that are more appropriate for specific types of dementias and are not appropriate for other types of dementias. There are interventions that are appropriate for some types of dementias that are not appropriate for other types of dementias. And so this is where differential diagnosis is crucial. In terms of the next steps of who do you refer to, again, it would depend upon how far along in the dementia progression that individual is. Because if they are at a very advanced stage and the diagnosis is really definitive, then you need to put in place supports for long-term care and eventually for palliative care. If they are at earlier stages, then it would be really crucial to ensure that you're building out other types of supports. And these include things like supports with logistics, with activities of daily living, things like helping to align banking and utility paying of bills, etc. But in terms of the specialist, that would really depend on what other types of investigations have also been conducted. Has it been in terms of the test for reversible causes? If there is a dementia, but there is also comorbidity with some other issues, how do you really ensure that there is appropriate pharmacological or medication management? And this is something really crucial in our context because many times persons are over-medicated, and because the doctors are not speaking to one another, there might be some interdictions between the medications. So that's really crucial. And so I hope that addresses your question, Sandra. If it doesn't, please let us know.
Thank you. Thank you. Yes, it does.
Okay.
Thank you.
Great. We have an ongoing question from Barbara Campbell in the chat in terms of the hereditary possibility of Alzheimer's. So I think there are a number of important caveats to consider with this question. So if your mother and your grandmother were definitively diagnosed with Alzheimer's disease, then that's something to really be thinking through in terms of what tests and procedures were used to get at that definitive diagnosis, and did your mother and your grandmother actually have any other types of comorbidities that would be important to consider. There is a body of work that is growing about genetic predisposition and how high that genetic predisposition is, particularly in some populations. For example, there is an ethnic group from Colombia where there is a very high genetic predisposition because of the APOE gene, where they have this genetic predisposition for Alzheimer's disease. So this is where genetic testing could be important. If you have established that, for example, it was indeed Alzheimer's disease that was definitively diagnosed, then it might be something that you might want to explore, again, with the caveat that this is not actually available in most Caribbean countries. The other thing to consider is that hereditary is different from genetics. So you may have factors that you might share with your mother, with your grandmother, based on the exposures that you all have had. So for example, if you've all lived near a bauxite mine, then you've all been, generation after generation, have been affected by the toxins from that. Or if they've all been farmers inhaling a particular type of pesticide or using a particular type of pesticide, then they all have similar types of levels of exposure. This is where this concept that's known as epigenetics comes in, because it's not just your genetic profile, but it's really the environment as well that can really lead to what you see as similar types of effects across the generations. So I think there are many factors to consider in terms of thinking about whether or not you would be more likely. And then, of course, there is your own lifestyle and your own health conditions. So if you have a better management of your non-communicable diseases, for example, if you are you're exercising regularly, if your diet and nutrition is of the type where you're not having a lot of fatty foods and processed foods and sugar intake, then you are actually ensuring that your nutritional profile is healthier. And that might actually be a protective factor in terms of any development of cognitive decline. So we are coming to a quick close of today's session. And yes, Dr. Roberts, we would love to hear from you.
Hi, guys.
Can we have... No, Dr. Roger Roberts was wrong, Dr. Roberts. Sorry, Ariel. I know it's confusing. I saw that Dr. Roger Roberts raised his hand. So, Roger, can we hear from you?
Hi, good evening. As I mentioned to you, Dr. Gavai, I'm a bit under the weather, but very informative session. And I think that the session basically underscored some of the things that we suspected, as in a vast majority of the patients have NCDs that are poorly treated. And we know that those are major risk factors. Sorry. Of course, there are several things to comment on, but I'll just keep it brief. I think that I opened up raise my hand to comment on 2 things, despite I could comment on many things, positive things, of course. One, in terms of the referral pathway, I think it's really important that once you suspect that someone has a dementia and you have done the initial workup as the GP, to get the patient to a specialist, if possible. Whether it's a neurologist, a psychiatrist, or myself as a neuropsychiatrist, even though appointment can be tight. And I'll tell you what I've noticed recently. The reversal of the causes are probably a little bit more common than people think. And it's really an injustice when we miss those causes, because it's an opportunity for a resolution of symptoms and normalization of functioning. And it goes beyond the general reverse of the causes that we have mentioned, and I know that those are standard internationally, but there are also some rare cases that, believe it or not, we're picking up a few of those in Jamaica. For example, autoimmune encephalitis masquerading as a dementia. Recently had a complex case just presenting atypically, and when I did the EEG, the lady has been having non-convulsive seizures, elderly lady. And one of the important things with a specialist, I'm not going to tell you that because we don't have biomarkers, we may not be able to narrow down the diagnosis as we ought to, but one thing is that our suspicion that something else is possibly going on would be very high, because we have seen a good caseload and would be more equipped to diagnose the common ones like Alzheimer's and vascular dementia. So when something comes outside of the norm, our suspicion will be very high. And that is one of the advantage in getting the patient to a specialist. The other thing I would say is that I've heard maybe one of the GP mentioned about trust, and the GP could continue to treat the patients. And of course, there's definitely an important role for the GP to play. But I would just want to take this opportunity to underscore that when we think about the symptomatology as it relates to dementia, they're quite complex. And ideally, if we're talking about optimal management of dementia, we're thinking about a modern kind of a specialized service. You're thinking about a multidisciplinary team approach. The patient with dementia is not just going to present with decrease in cognitive ability, but there's going to be the psychological symptoms, depression and anxiety that comes in the early stages. And treatment of these symptoms can improve the quality of life of the patient. And then you've got issues relating to mobility. Depending on the type of dementia, there may be need for physical therapy, then rehabilitative services, especially in the early stages. So your occupational therapists, speech and language therapists might be important. And that's what a modern memory clinic looks like. Dementia will affect multiple domains. And I think that we need to, at least in our conceptualization of different pathways, I'm hoping that we'll end up with a few specialist clinics that can provide highly specialized care to the cohort of patients that will benefit from such care. All right. As it relates to the question about the genetics in the chat, clearly there would be an important question to ask. You have mentioned some of the key points, Dr. Gavaya, but the grandmother, the mother, the individual asking about my risk. And one of the first questions I would ask, what age did they develop dementia? Because if it is a case that there is early onset dementia, particular of the Alzheimer's type, and we're talking about before age 65 when we say early onset, then there's a chance that there's a genetic component. And you mentioned about genetic testing not being readily available. It's something that I deal with from time to time. I've seen a few cases of early onset familial Alzheimer's, and people are quite worried. We will just describe it as dementia worry. May have high dementia worry in that case. But the way that I would package it, and I hope I'll be of benefit to the individual who posed the question, let's say that there is a genetic component and your risk is relatively high. Can you do anything at this stage to mitigate that risk? And the thing is that, no, you're not going to be able to mitigate the risk factor. However, you can delay the onset of the dementia by engaging in lifestyle changes, ensure that you manage your NCDs if you have those. We know about cognitive stimulation as you get older. Try to find new skill sets, new hobbies to stimulate the brain. Diet is important. We know that the research suggests that Mediterranean type diet might be beneficial in safeguarding against cognitive decline. So my advice to that individual is to do the right things in terms of both medical and non-medically, and that should reduce at least the time that you develop the illness if you're going to. But it's one of those areas we talk about genetic counseling, which we don't have well for dementia here in Jamaica. But would it change the outcome if, in fact, you have a early onset familial Alzheimer's or genetic related dementia?
Thanks so much, Dr. Roberts. And as you've mentioned, we have a number of collaborative initiatives in mind and in planning, including some of these specialized clinics and some of the specialized training. And this also gets to Dr. Ononuju's question in the chat about if it's possible to organize more online sessions that could facilitate the ways that we can assist doctors to better communicate with their patients, to help them pick up patients with early stages of Alzheimer's disease or cognitive impairment. Yes, Dr. Roberts, again.
Right, certainly. I think that the need for ongoing training is very, very important. I believe that when it comes on to dementia care, one of the things that I have noticed is that for my GP colleagues, some of them don't believe in the existing treatment. And we're talking about disease modifying agents. And yes, we're not there as yet, and it may take some time, meaning that before we get those agents here in Jamaica. But I think that those agents will become reality. There are more of those agents in development as I speak. But my concern is that the drugs that we have right now available to us, we're not using them appropriately. And I think that it is the idea of what treatment looks like that is a barrier. For the GP, if they prescribe the medication and the patient is not improving, there's a tendency to just discontinue and say that the medication is not working. But when it comes on to dementia care, the endpoint of the treatment may not be improvement, but stabilization, which means that the patient is not going to improve, but guess what? They're not going to decline as rapidly as they would have without the intervention. And I think that is very important. And once you provide that kind of education to the family members, you'll get that buy-in because they are realistic as to what the outcome is. They know that their loved one may not be improving, but the medication might be playing a role in slowing down the disease process, right? And don't underestimate what that brings in terms of the improved quality of life, the impact on caregivers, the delay in nursing home placement. So there are loads of benefit, even though you don't have that objective improvement in symptoms.
Thanks so much for that, Roger. That's so important, and this is why we do need this multidisciplinary team approach. One of our long-term partners is a clinic from Canada called the Mint Memory Clinic approach, where it's a multidisciplinary team approach, and we're looking for funding to be able to implement this with some of you, our core partners, who would be interested in implementing this type of model in your health practices, because we do appreciate the key role of this continued collaboration amongst the practitioners. We are definitely over time, but you all have continued to be engaged, and we're so grateful for that. Thank you so much for spending this time with us tonight, spending this time with us today. We'd especially like to say thank you to our panelists. Thank you to all of you, our attendees, for your questions, for your engagements. We are looking forward to this continued dialogue and conversation and action. As we'd say in Jamaica, action, not a bag of mouth. So we're looking forward to the work together to actually implement some of these changes. This webinar, as we've mentioned, was the first in a series of dissemination events about Jamaica's project findings. We are also coordinating with community partners and medical practices events to share the findings, and we'll be sharing the findings broadly, and if you are interested, also sharing the findings specific to your particular medical practice or patients, if you were a medical practice that participated. And we are, as we've mentioned, sharing these findings at national and regional conferences as well. This work would not be possible without the support and partnership from multiple local and regional entities and communities. And on the screen, you will see all of the partners who assisted and really facilitated the successful implementation of this project. We would especially like to thank our medical and health and allied care colleagues, the participants, and the research team for their key roles in the successful implementation of Jamaica's flagship project. A special thanks again to you, our attendees, for your engagement. A special thanks as well for our tech support. And as we sign off from the webinar, you will see 2 questions pop up. Please it just takes 5 seconds, I promise you. Please take the 5 seconds to respond to those, as they will help us to continue to provide more of what you are looking for. Let's keep this conversation going, and until next time, please take good care. Hi, Hopeland. We see that you have your hand raised and you're still on with us. Did you want to speak? Can you speak? Is your mic enabled? And I see that somebody else has their hand up. Okay. Talking permitted. I think, Hopeland, your mic isn't unmuted yet. Online counseling, we also see that you have your hand up and that you're still on with us. Would you like to speak as well? Oh, you don't have a mic icon. Okay. Okay. All right. Thank you, online counseling. Hopeland?
I don't know why this is going on.
I'm hearing you, but I'm not hearing you clearly.
I don't know. I'm logging off.
Okay. All right.
Yeah. Thanks.
Take good care.
Yeah,
All
man.
right.
You too.
All right. Bye.
Bye.
Bye.